Okay, so today's topic is stomach. We learn about blood supply and lymphatic drainage of the stomach. Okay, blood supply of stomach is very important. Okay, so first we will discuss brief anatomy of the stomach, its different presenting parts, then arterial supply and venous drainage, then lymphatic drainage. Okay. If blood supply of stomach comes, you have to write both arterial supply and venous drainage. Okay. Next, okay. So stomach, it occupies the left upper quadrant, epigastric and umbilical regions. Vertebral level is from T10 to L3 vertebral level. So this is the vertebral level T10 to L3 vertebral level. Position varies with body habitus. That means position changes during standing and lying down position. Okay. It has two curvatures. Here is the greater curvature. This is lesser curvature. And these are the presenting parts. Cardia, that is the cardiac end of the stomach. This part is fundus. Here is the body, and this part is pylorus. Okay, pylorus, pyloric antrum, and pyloric canal is present. Next, so stomach is a part of the foregut. Okay, so it will be supplied by branches from the celiac trunk. So what are the three main branches of celiac trunk? Left gastric artery, splenic artery, and common hepatic artery. Left gastric artery, it lies along the lesser curvature of the stomach and supplies the stomach and the lower end of the esophagus. Then splenic artery, it gives the short gastric arteries, almost 6 in number. Splenic arteries, these are also 6 in number, supplying the spleen. Short gastric arteries supplies the fundus of the stomach. And left gastroepiploic artery. This lies along the greater curvature of the stomach. Then common hepatic artery, it gives cystic artery, mainly comes from the right hepatic artery. Right gastric artery lies along the lesser curvature of the stomach. Then gastroduodenal artery. Gastroduodenal artery, it again divides into right gastroepiploic artery, which lies along the greater curvature of stomach, and superior pancreaticoduodenum lies in the groove between the head of the pancreas and second part of the duodenum. And two hepatic arteries are given, right hepatic and left hepatic artery. Okay, so these are the branches coming from the common hepatic. Next, see, these are the branches. This is celiac trunk. From here, three branches are coming out. This is left gastric artery. Okay, this is common hepatic. Common hepatic is giving hepatic artery proper, and this gastroduodenal artery and right gastric. Left gastric and right gastric forming an anastomosis along the lesser curvature of the stomach. This gastroduodenal artery, it is divided into right gastroepiploic and superior pancreaticoduodenal, also giving supraduodenal, retroduodenal branches. So right gastroepiploic, you can see it is lying along the greater curvature of the stomach. Now this is tortuous splenic artery. Okay, splenic artery is giving supply to the spleen. It is giving branches, short gastric artery supplying the fundus of the stomach, and one branch is extending along the greater curvature of the stomach, that is left gastroepiploic. It is anastomosing with the right gastroepiploic. Okay, and sometimes there is presence of posterior gastric artery. Here, these are the positions of the posterior gastric artery. Okay, so these are the blood supply of the stomach. Next, now, okay, first the left gastric artery. There are different variations of arising of these arteries. Okay, 90% cases it arises from celiac trunk. 4% from gastrosplenic trunk. Okay, that means left gastric and splenic artery arises by a common trunk and then they are dividing. In 3% cases, direct aortic origin directly arising from abdominal aorta, and 2% cases from hepatogastric trunk arises along with the common hepatic artery. So these are the different variations. Branches, it divides into anterior and posterior branch before entering the lesser curvature. Okay. So here it is giving anterior and posterior branches to the stomach, supplying anterior and posterior surface of the stomach. Next we go to the right gastric artery. See, here is the right gastric artery. Most of the cases it is coming from proper hepatic artery, proper 50 to 68%. Left hepatic from 29 to 40%, and from common hepatic 50%. And other less frequent sources are also can be present. Next is gastroduodenal artery. See here, this is gastroduodenal arises from the common hepatic artery and branch, which is a branch of celiac gland. It is a splenic artery, and some of gastroduodenal artery are very rare and are often missed preoperatively. Okay, if you miss preoperatively during surgery over the stomach or surrounding area, duodenum or pancreas, there will be heavy bleeding. Okay. Next, right gastroepiploic. This is a branch of gastroduodenal. See here, this is right gastroepiploic. Occasionally arises from superior mesenteric artery or anterior superior pancreaticoduodenal artery. Other common sources of origin. Next, for omental viability, this is one surgical importance during distal gastrectomy. Okay, in cancer of the stomach or during any peptic ulcer perforation like this, sometimes gastrectomy can be done. So for omental viability, omentums are attached along the lesser curvature, lesser omentum is attached along the greater curvature, greater omentum is attached to the stomach. So for the omental viability, during distal gastrectomy, the right gastroepiploic artery should be preserved by these following methods: ligating its gastric branches, or ligating the anterior epiploic, or ligating the right gastroepiploic distal and close to the origin of the right epiploic. Okay. Next, now left gastric 6% cases arises from splenic artery directly, and in 66% cases from splenic artery by a common stem with inferior polar splenic branch. And it is the largest branch of splenic artery, left gastroepiploic, along the greater curvature of the stomach. And with branches of right gastroepiploic, it is forming arc of Barkov. Okay. Next, see here, this is right gastroepiploic, there is left gastroepiploic. They are forming a continuous arch along the greater curvature of the stomach, and they are also supplying the omentum. This is greater omentum. Okay, other end is attached to the transverse colon, and in this region, branches from this right and left gastroepiploic, they are forming a arch. Okay, this is known as arc of Barkov. This is for supply to this greater omentum mainly. Okay. Next, there is one surgical importance in splenectomy. Ligation of the splenic artery and vein should be located distal to the origin of left gastroepiploic vessel, and the splenic vessels should be ligated very close to their entrance into the spleen to avoid the postoperative bleeding, which follows the ligation proximal to the origin of left gastroepiploic artery. Okay. So you have to ligate it very close to the spleen, hilum of the spleen. Next is short gastric artery. There are the short gastric artery. They are branched from the splenic artery or sometimes from left gastroepiploic artery. supplying the fundus and upper part of the body of the stomach. And these shorter vessels are the troublemakers in splenectomy, and you have to careful ligation is done, and imbrication of greater curvature is a safety measure to avoid bleeding or possible necrosis with perforation. All the arteries present, they are mainly 5 to 6 in number, short gastric, all the artery you have to ligate during the splenectomy operation. Next is posterior gastric artery. It arises from proximal, middle or distal segment of the splenic artery here. This is posterior gastric artery. Here it is arising from the proximal segment of the splenic artery. This posterior to the stomach, here lies the tortuous splenic artery. Okay. And inadvertent ligation or division of the artery can cause complication including focal necrosis and postoperative hemorrhage. Okay, these are the complications. And the posterior gastric artery has also been referred to as the accessory left gastric artery or ascending posterior esophagogastric artery. This is not that much important. Rest of the arteries are very important. Two gastric arteries, left and right, two gastroepiploic artery, short gastric artery. All those you have to write. Okay, during writing the blood supply. Next. Now arteries of the distal esophagus and proximal stomach. Another artery is supplying this area. Inferior phrenic artery supplies margin of the hiatus, esophageal hiatus, and esophageal branch of left gastric artery. This is left gastric. This is esophageal branch of the left gastric artery. It supplies the distal esophagus and passes through the hiatus to anastomose with thoracic esophageal arteries. Okay. Next. So these are the arteries supplying the stomach. See, this is abdominal aorta. From here, celiac trunk is arising. Three branches of celiac trunk: left gastric, splenic, common hepatic. Left gastric is lying along the lesser curvature and giving some esophageal branches for the distal end of esophagus. Splenic artery is tortuous, going to supply the spleen. It is giving short gastric arteries and left gastroepiploic artery for greater curvature and omentum. Then common hepatic artery is giving hepatic artery proper, right gastric and gastroduodenal. Gastroduodenal again giving the right gastroepiploic and superior pancreaticoduodenal. Right and left gastroepiploic lying along the greater curvature, supplying greater curvature and the omentum. Okay, so these are the arteries supplying the stomach, and sometimes posterior gastric artery is also present. Next, so you have to practice a schematic diagram of blood supply of stomach. Okay, understood? Okay, now arterial circulation of the gastric wall and its surgical importance. Each of the smaller branches of the major arteries, they perforate the muscularis, that means the muscular layer of the stomach, and supplies the submucosal plexus. Mucosa of the lesser curvature, it is supplied by small extrinsic branches of the left and right gastric arteries rather than by vessels from the submucosal plexus. Ligation of extrinsic arteries will not control the bleeding from the gastric ulcer because there is plexus formation in the submucosal region, and the stomach remains viable after ligation of all the arteries except the right gastroepiploic artery and right gastric artery. Okay. Next. And in obesity also partial gastrectomy can be done. Okay. With subtotal gastrectomy, the gastric remnant remains viable with circulation from left gastroepiploic artery and the short gastric artery, because the left gastric artery is ligated in subtotal gastrectomy. With 90 to 95% of gastrectomy, the remnant stays alive and well because of descending esophageal arteries in subtotal gastroctomy. And the blood supply of proximal gastric pouch depends on these three sources: ascending branch of left gastric, short gastric, posterior gastric artery if present. Adhesion of this posterior gastric wall must not be cut, as such adhesion may contain this posterior gastric artery. If it is injured, there will be heavy bleeding. Next we go to the venous drainage. Venous drainage of the stomach. Venous drainage is parallel to the arterial supply. It has same veins of same name as the arteries. Left and right gastric vein, left and right gastroepiploic vein, short gastric vein. Okay. So left and right gastric veins, they drain directly into the portal vein. Right gastroepiploic vein drains into the superior mesenteric vein, and left gastroepiploic vein drains to the splenic vein. Okay. It was coming from splenic artery, left gastroepiploic, right gastroepiploic was coming from gastroduodenal, but it is draining into superior mesenteric vein, and left and right gastric vein directly into portal vein. You see the picture, you will understand. Next, see. Here is the splenic vein lying on the posterior aspect of the stomach. Splenic vein and superior mesenteric vein, these two are joining behind the neck of the pancreas to form the portal vein. So here is the portal vein. So you can see the left gastric and right gastric vein are directly draining into this portal vein. Okay. These short gastric veins, they are draining into this splenic vein. Left gastroepiploic vein draining into splenic vein, and this right gastroepiploic vein, it is draining into the superior mesenteric vein. Okay, so practice this schematic diagram for venous drainage of the stomach. Next we will discuss the individual veins. Left gastric vein, bleeding from, here is the left gastric vein draining into the portal vein. Here you can see the splenic vein. Okay. Left gastroepiploic vein, short gastric veins are draining into splenic vein, and inferior mesenteric vein also draining into this splenic vein. This is superior mesenteric vein. This right gastroepiploic vein is draining into superior mesenteric vein. Then this splenic vein and superior mesenteric vein joining to form this portal vein. Okay, portal vein is entering through the into the liver through passing through the right free margin of the lesser omentum. So bleeding from severed distal branches of left gastric vein can be profuse because of the anastomosis between the left gastric esophageal and hemiazygous vein. Okay. Next is right gastric vein. Here is right gastric vein, travels with the right gastric artery, and one important branch is the pylorus vein of Mayo. It is a tributary of the right gastric artery. See, this is pylorus vein of Mayo. It has some surgical importance. Okay, pylorus vein of Mayo. Next, venous drainage. Major variations are present in venous drainage. The inferior mesenteric vein enters the splenic vein in 30% cases, and inferior mesenteric vein enters superior mesenteric vein in 30%, and it enters the splenomesenteric junction in 30%. Okay, and right gastric vein enters the upper portal vein in 30%, lower portal in 30%, and enters the junction in 30%. Left gastric vein enters upper portal. All these are 30%. Okay. In the upper portal 30%, lower portal 30%, and enters the splenic vein in 30% cases. Okay. So these are the major variations in venous drainage of the stomach. Okay. During surgery, you can have any of these variations. That's why you have to keep this variation in your mind. Okay. So that you cannot injure these veins or arteries. Next, right gastroepiploic vein, it empties into superior mesenteric vein in most of the cases, and gastrocolic vein, Henle's gastrocolic trunk is present in 70% of the cases, and it is formed by confluence of the gastroepiploic vein and right upper colic vein. Okay. And the transverse mesocolon traversing along the anterior surface of the head of the pancreas. Okay. So this is one important vein, Henle's gastrocolic. Next, left gastroepiploic vein, here is left gastroepiploic, drains into splenic vein or into one of its terminal tributaries. Okay. And ligation should be placed as close as possible to the hilum of the skin to prevent injury to this left gastroepiploic vein, to prevent hemorrhage. Next, next is short gastric veins. They drain into the splenic vein or one of its tributaries. You see, these are the short gastric veins. Also, these veins may empty directly into the upper part of the spleen. Okay. Also drain into the upper part of spleen. Short gastric vessels should be ligated carefully and they retract easily, and together with the left gastroepiploic vein can be associated with post-operative bleeding. So during splenectomy, you have to be very careful. You have to ligate all these veins, left gastroepiploic vein, short gastric vein, and cut the splenic vein near its hilum. Okay. Next. So this is the venous drainage of stomach in short. See, this is splenic vein. This is superior mesenteric vein. Okay. Joining to form this portal vein. Left and right to this portal vein. Right gastroepiploic draining into superior mesenteric vein, and left gastroepiploic draining into this splenic vein. Short gastric veins are also draining into this splenic vein, and esophageal branches are also draining into left gastric vein. Superior pancreaticoduodenal vein is also draining into the portal vein, and pre-pyloric vein of Mayo. But first, this is named after Mayo, but first described by Laterjet. Okay. Next, next we go to the lymphatic drainage. Lymphatic drainage is important because cancer of the stomach, it mainly transmitted via the lymphatics. Okay. So these are the lymphatics. Lymph nodes you can see lying along the lesser and greater curvature. Okay. So these are the pyloric nodes lying along the pylorus. These are they are named according to the arteries along which they are lying. Okay. Left gastroepiploic nodes, right gastroepiploic node, left gastric nodes, right gastric node, and along the celiac trunk will be the celiac nodes, paracardiac nodes lying along the cardiac end of the stomach, and hepatic nodes lying along the hepatic artery. All these nodes help in lymphatic drainage of the stomach. Stomach is divided into 4 territories for lymphatic drainage. Okay, this is 4 zones are present. Zone 1, this part from here to here, this is zone 1. This is inferior gastric region. Okay. Then zone 2, here is, this is splenic region. Then zone 3 is superior gastric region, and zone 4 is hepatic region. Okay. Next, see here, from all the zones, mainly the lymphs are going to drain into this celiac nodes. Okay. Arrows indicate that most of the drainage finds its way to the celiac nodes. Next, left gastric lymph nodes drain area of both anterior and posterior gastric wall. Here is the left gastric nodes. Pancreatico-splenic nodes. Okay. Um, here lies the pancreatico-splenic nodes. They drain the gastric fundus and body. This shaded area, this is drained by this pancreatico-splenic node. Fundus and body of the stomach is draining here. Then right gastroepiploic nodes. Here is the right gastroepiploic nodes, drains the right half of the greater curvature, occasionally including the pylorus. And hepatic, pyloric, and left gastric nodes, all those drain this pyloric part of the stomach. There is the hepatic nodes along the hepatic artery, pyloric nodes, and left gastric nodes. All these drain this pyloric end of the stomach. Okay. Next, these are 8 important lymph groups of lymph node of the stomach. Paracardiac nodes, left gastric nodes at the left gastric artery, celiac nodes near the celiac trunk, suprapyloric nodes, infrapyloric nodes, right gastroepiploic nodes at the pathway of right gastroepiploic artery, pancreatico-splenic nodes at the pathway of left gastroepiploic artery, and upper gastric greater curvature nodes at the short gastric vessels, near the short gastric vessels. These are important lymph node groups for drainage of the stomach. Next, see, these are the nodes: right gastroepiploic, pancreatico-splenic along the left gastroepiploic nodes. And here is the suprapyloric node, infrapyloric node. These are the left gastric node, short gastric nodes. Okay, and this is paracardiac nodes, celiac celiac nodes. Next, and hepatic nodes along the hepatic artery. Next. So these divisions of lymph nodes are important. Lymph nodes are dividing into stations. Okay, up to frequent stations. According to the spread of cancer, you have to remove the lymph node groups. Okay. So, a classification of nodal stations in gastric cancer, Japanese Gastric Cancer Association have divided it in 1997. Anatomical definition of lymph nodes and lymph node locations. The regional lymph nodes of the stomach are classified into stations numbered from 1 to 20. Plus stations 110, 111 and 112. All these stations you have to learn during your surgery. Okay, gastrectomy is important operation. So lymph node stations 1 to 12 and 14 regional stations. Other lymph node stations are distant stations. 1 to 12 and 14 is nearby to the stomach and others are distant to the stomach. And metastasis means it represents M1. Okay, lymph node 16, 19, 10, 110, 11. These are regional nodes in case of direct invasion of the esophagus by the tumor. And lymph node metastases are classified as NX1. That means regional lymph nodes cannot be assessed. 2 N0, no regional lymph node metastasis. 3 N1 means 1 to 2 regional lymph nodes metastasis. N2 is 3 to 6 regional lymph node metastasis and N3 is 7 and or more regional lymph node metastasis. Then N3A and 3B is present. 3A means 7 to 15 regional lymph nodes are involved and N3B means more than 15 regional lymph nodes are involved. Next, these are the nodes. Okay, one where these stations are lying. One is lying right paracardiac, including those along the first branch of ascending limb of left gastric. Then 2 is left paracardiac, including those along the esophagocardiac branch of the subphrenic. Then 3A and 3B. 3A along the lesser curvature nodes along the branches of left gastric. 3B lesser curvature along the second branch of distal part of right gastric. Then 4 SASB and 4D. SASB left greater curvature node along short gastric, left greater curvature, left gastroepiploic. Okay? And 4D is right greater curvature lymph node along the second branch and distal part of right gastroepiploic. Then 5 is suprapyloric node, 6 is infrapyloric node, 7 is lymph node along trunk of left gastric between its root and the origin of its ascending branch. Then 8 AP. A means anterior superior lymph nodes along the common hepatic. 8P is posterior lymph node along the common hepatic. Then 9 is celiac nodes along the celiac artery. 10 is splenic hilar nodes, including those adjacent to the splenic artery, distal to the pancreatic arteries, and those along the left gastroepiploic artery, proximal to its past gastric bladder. And 11PD proximal splenic artery, and this is distal splenic artery nodes. And 12 is hepatoduodenal ligament along the hepatoduodenal ligament. Next, then 13 lymph node on posterior surface of pancreatic head, cranial to the duodenal papilla. Then 14 V lymph node along the superior mesenteric artery. Until 14 V, they are lying around the stomach. After rest of the lymph nodes are lying away from the stomach, but they are removed if there is distant spread has occurred. Okay, so 15 lymph node along the middle colic, 16 A1, A2 para-aortic lymph node in diaphragmatic aortic hiatus. A2 is para-aortic lymph node between the upper margin of origin of celiac artery and the lower border of left renal vein. Para-aortic nodes, these are both para-aortic nodes, different position. Lower border of left renal vein, and here is upper border of origin of superior mesenteric artery and aortic bypass. Then 17 lymph node on the anterior surface of pancreatic head behind the pancreatic seed. Then 18 is lymph node along the inferior border of pancreatic body. 19 is infradiaphragmatic lymph nodes predominantly along subphrenic artery. 20 is paraesophageal lymph nodes in the diaphragmatic esophageal hiatus. Then 110, 11 and 12. 10 is paraesophageal lymph nodes in the lower thorax. 11 is supradiaphragmatic lymph nodes which separate from the esophagus. And 112 is posterior mediastinal nodes separate from the esophagus and the esophageal hiatus. Okay. Okay, so proximal spread, if spread occurs towards the thorax. So all those lymph nodes you have to know during surgery of carcinoma stomach. Okay, understood? That's for gastrectomy operation only you have to know the lymphatic drainage. Okay, because lymphatic spread is more common in carcinoma of the stomach. Okay, okay, that's all. Any queries? So you have to know, practice a schematic diagram for arterial supply and venous drainage of the stomach, and for lymphatic drainage you practice the diagram, the 4 zones. Okay, inferior, gastric, superior gastric, splenic, hepatic zones and their drainage. These 4 areas and their drainage lymph nodes. That part you have to write. And if comes as a question, this mainly comes in your surgery paper, 20 lymph nodes. Okay, for their location. Okay, that's all. Any queries?
Good morning, students. Yesterday we start the topic of nucleotide metabolism. In the nucleotide metabolism, we already complete purine metabolism, synthesis and catabolism. We complete both the parts. Okay. Now today we are going to start with the clinical manifestations of purine metabolism. After then, pyrimidine metabolism. And today we are going to finish the topic. Okay. So, as you already know that the primary defect of purine metabolism is gout. So I will tell some of this gout related some silently features, then we discuss pyrimidine metabolism. Okay. So what is gout basically? Metabolic best product of purine metabolism. Purine metabolism. Increase to how much? Question is that before that you have to know the normal value of uric acid. The normal value of uric acid is 5 to 7 mg per dl, and for 5 mg per dl. If the value of this uric acid is high, is there is uric acid production is more. This condition referred as hyper. But it is only a clinical sign that a hyperuricemia occur. But when there is overproduction of uric acid, what happens? They can firstly on your great toe. जो पैर का अंगूठा होता है ना, उसके आसपास यूरिक एसिड का डिपोजिशन होने लगता है. देयर इज डिपोजिशन ऑफ यूरिक एसिड इन ग्रेट टो एरिया विच कॉजेस इन्फ्लेमेशन. The question is that why their uric acid production is high? Why their uric acid production is high? Okay? If you know uric acid, that purine metabolism is basically what? It is a metabolism of DNA and RNAs which you take in your dietary sources. First thing is that. Okay? So, inflammation, arthritis, and causes arthritis. इन्फ्लेमेशन मीन्स पॉलर जो भी आपका इडिमा होता है, टेंडरनेस होती है टच करने पर, देयर इज अ पेन आफ्टर टचिंग. ओके, ऑल दीज थिंग्स आर अपीयरिंग. You better understand with the slide. Okay, so this is basic things we complete here. Okay, I already tell you it is a metabolic disorder associated with elevated level of uric acid. The increased serum uric acid due to increased formation of uric acid and decreased renal excretion. That means it is ultimately correlate with the kidney function. Okay, it is hyperuricemia and it is not all associated with the gut. But this means a person having high level of uric acid, but it doesn't matter that the person having suffer from gout. That is means. But if you understand the sign and symptom, then we go for causes. That is the as tophi in soft tissues. Okay? Tophi in soft tissue. Such kind of inflammation occur. Such kind of swelling occur in such kind of patients. Okay? How it is deposited, in which form, you understand that. By extruding pain. When the uric acid is increases, what happens firstly in the gout? When the uric acid is increases, it can precipitate it and it deposits in the tophi. In the relative fluid. The kidney there is what causes stones. Okay, stones. Now we see main detail of all this. You understand point by point. Classification of gout, it is mainly primary gout and secondary gout. Okay, primary gout is basically by the overproduction of uric acid. Overproduction of uric acid by which metabolic pathway? Purine metabolism. Okay, because uric acid is produced by purine metabolism. In primary gout, increased level of uric acid is associated with increased synthesis of purine nucleotide. Basically, now increased synthesis of purine nucleotide is caused by defective enzyme of purine nucleotide biosynthesis. These all are the enzymes in which HGPRTase is a regulatory enzyme. HGPRTase is a regulatory enzyme. Due to defect in this enzyme activity, ultimately they can lead to increase the overproduction of uric acid. Okay, and these all are the primary causes of hyperuricemia, primary causes of uric acid. Okay, PRP synthase, there is increased activity of PRP synthetase, increased activity of PRP glutamate aminotransferase, HGPRT deficiency, G6 glucose 6 phosphatase deficiency. So all these are considered as a primary cause. And symptoms of primary gout is what? They are elevated and increased concentration of uric acid in the blood and tissues. Increased concentration. How much concentration normal value having? It is 5 to 7 mg per dl for male, and for female it we already given the values. Okay, so they are increased production. What happens? The joint become inflamed, painful, and arthritis due to abnormal deposition of sodium urate crystals. Patient with primary gout often show deposition of urate as tophi, clusters of urate crystals. Mention this point, tophi, that means clusters of urate crystals in soft tissues that affect the joints and lead to painful arthritis, that affect the joints and causes arthritis. Arthritis means what? Arthritis means hardening of blood vessels. Hardening of blood vessels. That is called arthritis. Okay. The kidney also affected since excessive uric deposition in the kidney and formation of renal calculus. Basically, if there is more productions of uric acid occur, high level of uricemia occur for a prolonged time, that means there is defect in the renal tubules area which causes monosodium in the renal and ultimately form renal calculus. If this renal calculus persists for a more time, then it leads to renal failure. Okay? You will see that is such kind of tophi is formed in such patient of primary gout. Okay? And these crystals appear in the kidney tubules. This is called monosodium urate crystals, which is formed by the excessive production of uric acid. Okay? It is primary gout. Now secondary gout. Secondary gout is what? Secondary gout is resulted by variety of disease that cause an elevated destruction of that cell which occur in cancers, psoriasis and hypercatabolic states. That ultimately lead to increase the level of uric acid, but it is not related with purine metabolism. But it is not related with purine metabolism. If you kept in your mind, there is hyperactivity of PRPP synthetase, hyperactivity of PRPP aminotransferase, okay, hyperactivity deficiency of HGPRTase, and hyperactivity of glu-6-phosphatase. That ultimately what? These all are the primary causes. And when the uric acid level is high, related with other disease like leukemia, polycythemia, psoriasis, and starvation and trauma, then it's to be called secondary gout. Decreased elimination of uric acid which occur in chronic renal disease due to reduced GFR. And last one is glucose 6-phosphatase deficiency. That is not a single point. You understand the basic concept, how it is lead to increase the uric acid, how it is increase the uric acid in glucose 6-phosphatase. Gluconeogenesis. Okay. If ribulose 5-phosphate, you will see for 5-phosphate increase the level of purine metabolism. Okay. Multiple step, there is a formula. Okay. Basically, you understand by the deficiency of glucose 6-phosphatase enzymes, these can lead to increase the substrate glucose 6-phosphate which can increase the substrate ribulose phosphate, and after the ribulose phosphate, it can increase directly by multiple step formation of uric acid. It is a secondary cause. This is a secondary cause of gout. I think all of you understand secondary cause. Now treatment is given. What kind of treatment you will follow up with such kind of patient? How will you manage such gouty arthritis? How will you manage? Firstly, you advise not to take any red meat, any cereals which contain nucleotides. Okay, this is first advice. After then, you will manage by drug. Which drug you use? I already tell you in the previous class, that is allopurinol. Allopurinol is what? This can inhibit xanthine oxidase enzyme, competitively inhibit xanthine oxidase, and through this we can reduce the level of uric acid. Okay? The drug allopurinol which can inhibit xanthine oxidase competitively. Okay? And gout. Those nucleotides and nucleic acid which will liver kind of diet. We suggest the patient not to take this kind of diet. Okay? Such kind of diet. Now, Lyshnian syndrome, that is very important. If there is HPRT deficiency, then there is increased level of uric acid, and this is genetic defect disorder. Genetic defect disorder, very important. You will always keep in your mind these questions asked in your exam in form of case studies. In form of case study. A patient comes in the OPD complaining of pain in the top eye, having high uric acid level, what are the causes, and taking the red meat. Okay, then question is like that, write provisional diagnosis, how will you manage the patient, explain biochemical defect. Okay, same as in the case of Lyshnian syndrome. A child is suffer from self-mutilating symptoms. Self-mutilating means a child can hurt himself. खुद को ही नुकसान पहुंचाते हैं. ठीक है? It is a X-linked deficiency disorder, and which is complete deficiency of HGPRase, which enzyme involved in purine salvage pathway. That is another. Okay? What happens if there is HGPRase deficiency? The purines cannot be reconverted into nucleotides, then it is degraded out to uric acid. Okay? So ultimately, what happens? The increased purine synthesis, the degradation of products, uric acid also increase, and same the uric acid level increase in plasma, and urine and gout and some other tissues are damaged. Ultimately, there is a overproduction of uric acid. But symptom is very important. Such symptoms are, first one is hyperuricemia, high level of uric acid, gout, urinary tract stone, neurological symptom of mental retardation, spasticity, okay, and self-mutilation. That is very important. Self-mutilation. If such symptoms come in the case study, if such symptoms is mentioned in the case, then you easily understand that is the case of Lyshnian syndrome. That is simply the case of Lyshnian syndrome. This symptom is self-mutilation. What is that? Self-painful destruction behavior of beating of fingers and lips. अपने lips को काट लेना, अपने हाथों को काट लेना. That is called self-mutilation symptoms. And this is mainly occur in Lyshnian syndrome. Okay? Treatment I already given. Now severe combined immune deficiency, that is another disorder. There is adenosine deaminase deficiency occur. We have some biochemical test, blood test, synovial fluid examination, urinoanalysis. There is overproduction of uric acid, HGPRase, or molecular genetic test. So all these are the testings. You read this. There is nothing. Now we start the pyrimidine metabolism. Okay, pyrimidine metabolism, that is important. These all are the sources of carbon and nitrogen molecule of this ring. Aspartate concept here, synthesis, there is a formation of this ring. And it is same like that, but in purine metabolism there is the substrate is ribulose 5-phosphate, but not in the case of pyrimidine. Okay, there is the formation. Okay, we understand this, the formation of this thing by different metabolic, by single metabolic pathway. In this, that there is formation. Carbonyl phosphate, in which the it is a cytosolic enzyme. It is a cytosolic enzyme. Where is CPS1? No. No in the uric acid. Urea cycle. Yes, CPS1. It is mitochondrial enzyme, but it is a dihydroorotate. Write this cycle. Write this cycle along with me. Okay. Di orotic acid. Orotic acid. Orotic acid. by with help of hydroorate dehydrogenase. What acid is formed? Uric acid formed. With the help of enzyme, OPRT, OPRT stand for orotate phosphoribosol transferase. Orotate phosphoribosol transferase. Okay, this is the step 5th. Okay, oratory. There is a formation of UTP. And this cytidine triphosphate, it is called CTP. Okay. Monophosphate. For nucleotide is this RR stand for ribonucleotide. These nucleotides are formed. These pyrimidine nucleotides are formed by this metabolic pathway. This is called pyrimidine metabolism. This is called pyrimidine metabolism. So you easily understand by single concept that it contains nitrogen base. It is UMP. Okay, these are the nitrogen bases and these are different. Okay, so in the synthesis part, what we are going to study, what we are going to complete, pyrimidine molecules, and lastly, from what we get the substrate, it is CTP. Understand? So there is our in the lastly, what we get after the synthesis, we get enzyme CPS second. CPS second is a carboxyl phosphatase synthetase enzyme. Carboxyl phosphate synthetase enzyme, and it is a cytosolic enzyme. By this activity, what happens? Uracil and glutamine are combined with each other to form carboxyl phosphate, carmyl phosphate, and these carmyl phosphate is further going to convert into carmyl aspartate by the combination of aspartate transcarbamylase enzymes. Okay. In the next step, there is the formation of dihydroorotate by enzyme dihydroorotase enzymes. Dihydroorotase enzymes. So now we understand how many enzymes are there in this cycle. How many enzymes are in how many enzymes in this cycle? It is for you. You have to write this in this format. If you want to remember this metabolic pathway, you have to remember this enzyme. Stand DH for dihydroorotase. Okay. Enzyme. Last one is orotate decarboxylase. Orotate decarboxylase. These all are the enzymes which are in this metabolic pathway. Okay. This is bifunctional enzymes. Student understand? So here section there are two parts. The first one is synthesis, after then catabolism. Here synthesis part is over, and for all clear things we go for cycle in the slide also. You understand what I summarize from this slide, that it is a source. These are the sources of different nitrogen and carbon molecules in this cycle. Okay. For this you see the N3 nitrogen comes from glutamine, C4, C5, C6 and N1 comes from aspartic acid, and C2 comes from carbon dioxide. So ultimately these glutamine, aspartic acid, CO2 are forming this ring. So this is the partner. This is the first step, that is synthesis of this ring. How it is synthesized? With the help of this glutamine, aspartic acid and CO2. Now go for cycle, that is de novo pathway for the synthesis of pyrimidine nucleotides. De novo pathway means what? What is the meaning of de novo? Anybody can tell? पढ़ो, आगे देखना चलो. हाँ, yes, because de novo means there is no internal synthesization. We take in exogenous pathway, exogenous diet source of these nucleotides, then it is synthesized in our body. Okay. CO2 plus glutamine. Now we complete this metabolic pathway from this. This is carmyl phosphate synthetase first, aspartate transcarbamylase. Now you easily understand. Student, when you make this cycle, when you make this metabolic pathway in your copy with your hand, then you easily understand what is given in your books. And there is no other method to retain this cycle in your mind. आपको समझना नहीं है इसमें, सिर्फ आपको रटना, उसको याद करना है पूरी तरीके से. You have to learn by writing in different times. 5 बार उस पाथवे को लिखिए, आपको आ जाएगा. और ये क्वेश्चन सीधा सीधा आता है. ठीक है. Ultimately, there is the formation of uridine monophosphate. Okay. And this UMP, after the formation of UMP, lastly, we see this metabolic pathway from here. यहाँ से देखेंगे. ठीक है. Thereby the activity of kinase enzyme, there is formation of UDP, and these UDP form UTP, deoxyuridine diphosphate, and lastly deoxyuridine monophosphate and deoxy trimonophosphate. So ultimately this can carry 12 steps. We can form this pyrimidine structure synthesize. Okay. Now you different between CP. अरे ये तो पता ही आप लोगों, you already know what is CPS first, what is CPS second. NAG is the allosteric regulator of this CPS1, but it is not for CPS second. Okay. Now there are two main steps which is called regulatory step. You will mention, you write this step. The first one is carboyl phosphate synthesis, second and aspartate. Okay. So these all are the regulatory step of this cycle. These all are the regulatory step of this cycle. You also take the picture of this slide. It is very important. Okay, that is PRPP. PRPP means it can increase the rate of this cycle. Okay, and this UTP can decrease the rate of this cycle by CPS second. Okay, so these all are the synthesis regulation. Now we complete degradation. Dihydrouracil and dihydro. Okay. Amino beta hydroamino, right? And these forms these isobutyrate can form succinyl CoA. Succinyl CoA. Succinyl CoA and acetyl CoA. And lastly, by the formation of acetyl CoA and succinyl CoA, this is going in the next in further other metabolic cycle for the production of ATP. You already know acetyl CoA, utilization of acetyl CoA, and you already know what are the substrate molecule succinyl CoA is, where it is going in other metabolic pathway. You will tell the name. ECG. Huh? TCA cycle, very good. TCA cycle, and where it is given acetyl CoA, metabolic rate of acetyl CoA. Tell where acetyl CoA is going. बोलो. हाँ? थोड़ा लाउडली बोलो. You don't know what is the substrate of acetyl CoA is substrate for which cycle? हाँ, beta oxidation. Okay, so these are the degradation of pyrimidine. Degradation of pyrimidine. Okay, now we see the slide. Catabolism of pyrimidine nucleotides ultimately give these products. These are the end products: CO2, NH3, beta alanine, isobutyrate. Okay. You will see that cytosine, uracil, thymine, which form dihydroxyl diethylthymine, beta alanine, and amino isobutyrate, and further it produces CO2 and NH3. This is the catabolism. You already know all these things. Now, disorder related with pyrimidine metabolism. Disorder. We complete synthesis, we complete degradation. Okay? Now, disorder. There are first disorder is uric aciduria. Uric aciduria. Uric aciduria. Please tell me where it is happen. By the deficiency of enzyme dihydroorotate dehydrogenase. OPRTase. OPRTase. By uric aciduria and Rare syndrome, these are the syndrome where this deficiency of OPRTase, this can lead to the deposition of orotate, which we called uric acid. Okay, and these uric acids accumulate in the body and this is excrete in the urine. So this one is uric aciduria and this one is Rare syndromes. Now, how the anti-cancerous drug helpful for stop this metabolic pathway? You understand that either we take methotrexate, it is anti-cancer drug, or flavodeoxyuridine, it can thymidine synthetase enzymes को inhibit करेगा, and these dihydrofolate reductase is inhibited by methotrexate enzymes. You will just take the cycle, photo of this cycle, click कर लीजिए मोबाइल में. That's these anti-cancerous drugs, methotrexate and aminoterapin, inhibit dihydrofolate enzymes. Okay, dihydrofolate enzymes, and these ultimately reduce the formation of pyrimidine. Here we complete nucleotide metabolism. Now I summarize it. You listen carefully. Okay? How can you complete it? Why we required salvage pathway? Anybody from last bench? Why we required salvage pathway? I will give the answer in previous class. Tell me. Why we required salvage pathway? I will tell you already. In our some tissues and organ of the body are not capable to synthesize purines by de novo synthesis. Then they go for alternate sources. That is called salvage pathway. This is the RBCs, our brain cells. Okay, all these perform salvage pathway. After then, we already complete gout in detail. Lymphatic syndrome. Okay, the case comes from this disorder. अब case कैसा आएगा? How cases comes like that? A child comes in pediatric OPD with a complaint of self-mutilation, with a complaint of pain, with a complaint of mental retardation. Okay, and these all are the biochemical parameters in which you will see high level of uric acid is occur. Now you write provisional diagnosis. Then you will write first provisional diagnosis is Leishman syndrome. What is the biochemical defect? Then you will write there is deficiency of HGPRase enzyme. Okay. Then next question is comes, why this uric acid level is increases? Then you will tell it is a salvage pathway enzyme. If the enzyme is deficient, then can lead to increase the uric acid level. Understand? How will you write the case? It is simple. Cases comes like that. A child is comes in the pediatric OPD complaining of self mutilation. Self mutilation, you know, अपने हाथों को काटना, अपने लिप्स को काटना, अपने आप को नुकसान पहुंचाना. Self destruction. It is called self mutilation. Okay. Other symptoms are hyperuricemia. Okay. Up now question is comes, write provisional diagnosis. You will write it is the case of Leishman syndrome. Biochemical defect, simply you will write it, there is a deficiency of HGPRase. What is the cause of hyperuricemia? It is the enzyme of salvage pathway. If the enzyme is deficient, there is overproduction of this. Beta alanine, sorry, acetyl CoA. These can degrade it into this. And lastly, metabolic from this premium metabolism is in your exam is only one, orotic aciduria. Orotic aciduria. And Reyes syndromes you will see in your book, it is given already. Reyes syndromes. Okay. And here nucleotide metabolism is over. Nucleotide metabolism is over. I think you all clear this concept. I will give you in detail and cover all the points. If you have any queries regarding this topic,
PFT or pulmonary function test. Give a heading PFT. Under PFT, we have a plethora of tests. Okay, PFT or pulmonary function test, or you can also say lung function test. Okay, we do not use the term lung function test because LFT is different. It is liver function test, right? So use PFT. PFT means pulmonary function test. Pulmonary function test comprises of few plethora of tests. So number one, to write spirometry with BDR. Okay. Number one is spirometry with BDR or bronchodilator reversibility. Number two is DLCO, diffusion capacity of lung for carbon monoxide. Okay. Number three is total body plethysmography. I will repeat. Total body plethysmography is number three. And number four is EtCO2, capital E, small t, then CO2. CO2 is carbon dioxide, right? End tidal carbon dioxide. End tidal carbon dioxide. EtCO2. E capital, T small, then CO2, right? I repeat, pulmonary function test doesn't mean a single test, right? It comprises of few tests. So most importantly, which is in your syllabus is spirometry with BDR, right? Spirometry with BDR, capital B, capital D, capital R, which means bronchodilator reversibility. Bronchodilator reversibility, right? Second is capital D, capital L, CO, DLCO. DLCO means diffusion capacity of lung for carbon monoxide, right? With this test, we check the diffusion barrier, okay? Number three, total body plethysmography, PLETHYS, MO, then graphy, plethysmography, okay? And number four is EtCO2. So these are the tests which are included under pulmonary function test or lung function test, okay? And remember, in your syllabus, it is spirometry with BDR, what you need to know, okay? But also you need to know the basic principle of EtCO2, basic principle of DLCO, and basic principle of total body plethysmography, right? So to begin with spirometry, first of all, you need to know what will be the patients, what will be the symptoms of patient, symptomatology of the patient, where you will advise this test, right? So, pulmonary function test or spirometry with BDR is a very common test which is advised by the physician or the clinician, right? Usually to diagnose a respiratory disorder, right? So, in our case, assume a patient is complaining of shortness of breath, shashkosto, right? Respiratory distress. Now, you know that respiratory distress or shortness of breath, dyspnea, it may arise from abnormality of two systems. One is respiratory system, another is cardiovascular system, okay? Say for example, there is heart failure, right? So, congestive cardiac failure or heart failure, right? The patient will be complaining of respiratory distress, but it is not a problem of respiratory system, it is usually a problem of cardiovascular system, right? Again, another patient, same complaining of respiratory distress, right? But the patient is of bronchitis or bronchial asthma, right? So, this is not a problem of cardiovascular system, this is a problem of respiratory system, right? Okay, and you also know the examination protocol, how to deal with the patient, right? So, patient is complaining of respiratory distress. Now, your first job is to take the history, right? You will take the history. What kind of history? So, the patient is complaining of shashkosto, right? Respiratory distress. Now, you will expand it. শ্বাসকষ্ট কখন বেশি হয়, শীতে বেশি হয় না গরমে বেশি হয়, রাইট? ডাস্ট এক্সপোজারে বেশি হয় নাকি শুলে বেশি হয়, ঠিক আছে, দিনের কোন সময় বেশি হয়, এভরিথিং, ঠিক আছে, এভরিথিং ইউ উইল talk with the patient and you will take detailed history. This is your first job, right? And most of the time history will give you clue whether it is a problem of respiratory system or cardiovascular system. Say for example, if the patient is complaining that my respiratory distress increases when I lie down, আমি যখন শুয়ে পড়ি তখন আমার শ্বাসকষ্ট বেশি হয়, right? So it will indicate the respiratory distress of heart failure, right? We call it orthopnea, right? শুলে শ্বাসকষ্ট বেশি হয়, orthopnea, right? Okay, next we will ask about the history of smoking. If the patient, in the patient, if there is history of smoking, it will go in favor of bronchitis, COPD, emphysema, like that. And if there is any history of allergic condition or exposure to dust and aggravation of symptoms, it will go in favor of bronchial asthma, right? And bronchial asthma most commonly it is seen usually in children, but not necessarily adults will not suffer from bronchial asthma. There may be bronchial asthma as well in adult population as well, but it is most commonly seen in the children population, right? Okay. Okay, so first you will take history. Second, you will do general physical examination. You already know what is general physical examination. Under general physical examination, we look for some points. One is anemia, cyanosis, jaundice, clubbing, edema, neck vein, neck gland, and few vital parameters like blood pressure, pulse, temperature, and oxygen saturation, right? So these are the parameters you will check under general physical examination. Whatever be your patient, general physical examination is must for any patient. Taking history, then general physical examination. Okay. Now combining all the data, what you have acquired from history taking and general physical examination, again you will get some clues, right? What the system is basically involved, right? Is it respiratory system or cardiovascular system, right? Okay. Still, if you are confused, you can do both system examination, right? So in our case, say for example, it is a condition of respiratory system. The patient is a child, right? There is a history of allergic condition, right? History of dust exposure and aggravation of symptoms, right? So in our case, we are suspecting it is a case of respiratory system. So we will do respiratory system examination. Okay. So under respiratory system examination, again, you know all the points. You will first do inspection. You will check shape of the chest, symmetry of the chest, right? You will look for the movement with respiration. All these are in inspection. Then inspection, after inspection you will do palpation, then percussion, then auscultation. So everything is, you know, right? We are not going into details of the respiratory system examination because this is not a class for respiratory system examination. Okay. Now history taking, general physical examination and respiratory system examination. Okay, definitely you are not going to check nervous system examination or abdominal system examination in a patient of respiratory distress, right? Okay, so you will do examination of respiratory system. And after respiratory system examination, there will be few diagnoses that will be playing in your mind, right? And now you will advise some investigations or test, laboratory investigation for the patients. You can do a chest X-ray, you can do a chest CT scan, maybe a normal CT scan or high resolution CT scan, depending on what is the diagnosis playing in your mind. If you are suspecting a pneumonia, right, you can do a chest CT scan. You can suspecting a lung SOL, cancerous something, you can do a chest CT scan. Then you can suspecting you are suspecting a pneumothorax or consolidation, you can do a simple chest X-ray scagram, right? And if you are suspecting any sort of obstruction or restriction, you can perform a pulmonary function test, right, which is today's topic, right? And under pulmonary function test, I told there are 4 different types of tests we can perform under pulmonary function test, out of which spirometry with BDR is most important for you and which is included in your syllabus under CBME curriculum by NMC, right? Okay. So moving on to spirometry. So before moving to spirometry, a few things I guess you already know from your 10+2 knowledge. We have some parameters. We have some lung parameters, right? And few parameters are known to you already. We divide, you write lung parameters, okay? Lung parameters. So we have some volumes and some capacities, right? We have some volumes and we have some capacities, okay? So lung parameters divided into two. One is divided into two. One is static parameter and another is dynamic parameter. Static parameter and dynamic parameter. Under static parameter, you write TV, tidal volume. You write RV, residual volume. You write TLC, total lung capacity. You write VC, vital capacity. You write FRC, functional residual capacity, right? Okay. Now move on to dynamic parameter. Under static parameter, within bracket you write do not depend on time. Do not depend on time, right? Under dynamic parameter, you write time dependent. Under dynamic parameter, you write time dependent. Okay. So very simple, very simple. You think of tidal volume, you think of residual volume. These are simple volume. Total lung capacity, vital capacity. These are simple volume. They do not depend on time, right? They do not depend on time. Now, some dynamic parameters. Under dynamic parameters, first you write FEV1. You do not know what is FEV1, I will explain. So, FEV1, write FEV and small 1, subscript. Okay? FEV, V e tolai choto kore 1. Okay? Subscript, FEV1. Written on the board, you can see. Okay? Then number 2, you write PEFR, which is called peak expiratory flow rate. Peak expiratory flow rate, right? Next, number 3, you write MEFR, which is called mid expiratory flow rate. इसका और एक नाम है, ठीक है? MEFR/MEF 25 to 75, written on the board. You can see. Okay? MEFR or MEF 25 to 75. Okay, both are same. It is also called mid expiratory flow rate. Mid expiratory flow rate, right? Number 4, you write FEV1 by FVC. FEV1 by FVC, again written on the board, you can see. FEV1 by FVC, right? Okay, so all these parameters, they depend on time, right? Okay. Okay, now let me explain. You have known some time dependent parameter and you have known some time independent parameters. Time dependent parameters are called dynamic parameter and time independent parameters are called static parameters, right? I guess most of you know what are static parameters. Okay, I am breathing normally. Air in, air out, air in, air out, air in, air out. How much amount of air I am taking? Tidal volume, not 500 ml. 500 ml is the standard. It is usually 6 to 8 ml per kg, right? 6 to 8 ml per kg. If I am 70 kg individual or 80 kg individual, say for example I am 80 kg, right? 80 kilogram. So my tidal volume will be 80 into 6. So 480 ml. Okay, never say 500 ml. That is your 10+2 knowledge. Okay, so tidal volume is 6 to 8 ml per kg. Okay, also it depends on sex. It depends on body mass index, right? So there are so many parameters upon which your tidal volume depends. Okay, it depends also on age and smoking status. Okay, if I smoke, my tidal volume will decrease. Okay, usually. Okay, so you know what is tidal volume? Tidal air I am taking, tidal air I am exhaling. Tidal air in, tidal air out. Now I have decided to release all the air from my lung. Okay, release all the air forcefully from my lung. Now what amount of air is remaining in my lung? What? RV, that is residual volume. Okay, RV or residual volume, because RV is the volume which you are not able to out from your lung. Okay, harder you can try, harder and hardest you can try, you cannot out your residual volume. It will remain inside lung. Okay, whatever force you can apply, okay, whatever force you can apply, you cannot exhale your residual volume. That will remain within the lung, and it is around 1.2 liter. Okay, you know everything, these parameters. Okay, now again I am deciding to fill my lung all with air with maximum effort. Okay, I will expand it maximum. I will expand my two balloons maximum, right? So I am taking air in. Okay, what is my lung volume? Total lung capacity 6 liters. Okay, average 6 liters, not 6 liter for everyone. Okay, so I am at total lung capacity, right? Right now I am at total lung capacity. Okay, now I have decided from total lung capacity I will exhale all the air and I will go to RV. Okay, now I am at TLC, I will exhale all the air. Now I am at RV. How much amount of air I have exhaled? Vital capacity. Okay, so say for example my total lung capacity is 6 liter and my residual volume is 1 liter, say for example, okay. So 5 liter is my vital capacity. Okay, 5 liters is my vital capacity. Okay, okay. Now instead of releasing vital capacity, I am breathing normally, tidal. Okay, tidal volume 500 ml in, 500 ml out, 500 ml in, 500 ml out. So normally I am breathing. Okay, so 500 ml in, 500 ml out. I am at this position. How much amount of air inside my lung? FRC, functional residual capacity, right? Okay, okay. So now see this graph, tidal in, tidal out, tidal in, tidal out. So tidal in, tidal out, the amount of air remaining is FRC, right? Amount of air remaining is FRC. Now with force I am releasing all the air as much as possible from my lung. The amount of air remaining is residual volume. Okay, now I am taking maximum air to fill all my lung. I am at TLC. Okay, now from TLC to RV I will release forcefully all the air. I will release the VC amount of air, vital capacity amount of air, right? Clear everyone? Okay, so by now you know all the static parameters. These are all static parameters: FRC, tidal volume, vital capacity, total lung capacity, residual volume. Everything are static parameters. They do not depend on time, right? They do not depend on time. Now you need to come to the dynamic parameters. Okay, see dynamic parameters. First dynamic parameters you have written is FEV1. Okay, so what is FEV1? Let us understand. What is FEV1. Okay, FEV1. Before telling FEV1, I will tell you PEFR, peak expiratory flow rate. Okay, there is a requirement for that, right? So what is PEFR, peak expiratory flow rate? Again, I need to explain. Say I am at TLC, I am at total lung capacity, and my decision is I will come to RV. Okay. Say for example, this whole process of releasing vital capacity amount of air from TLC to RV, it takes 5 seconds. Okay. How was my TLC? 6 liters. Okay. What is my residual volume? 1 liter. So from TLC to RV, I will release how much amount of air? 5 liter. 5 liter I will exhale. Say for example, this whole procedure takes 5 seconds, right? That doesn't mean you are releasing 1 liter of air every second. That doesn't mean, because the rate is not constant always. At the beginning, from TLC to RV, initially I am releasing more air, and as I am reaching towards RV, the flow rate is decreasing. Okay. So, throughout the process, maximum airflow rate is called peak expiratory flow rate. Okay. In the unit of liters per minute, liters per second. Okay. In the unit of liters per second. Clear? In the unit of liters per second, peak expiratory flow rate, the maximum flow rate. Okay. Where is the maximum flow rate? It can be measured by the machine, right? You don't need to worry. There is peak flow meter, there is spirometry machine. Okay. So the machine will determine. Okay. So we will measure the peak expiratory flow rate, right? Okay. Next parameter, what I'll tell is FEV1 or forced expiratory volume in first second. Forced expiratory volume in first second. So what I told, from TLC, total lung capacity, to residual volume, it takes 5 seconds of time, right? And total I am releasing 5 liters of air. Okay. In 5 seconds I am releasing 5 liters of air. Now this FEV1, this parameter is amount of air released in first second. Okay. Amount of air released in first second. It is called FEV1, forced expiratory volume in first second. Clear? Okay. Now MEFR. MEFR is mid expiratory flow rate. Total time span is 5 seconds. You divide it, you take the mid 50%. Okay. So total time duration you see is 5 seconds, right? Total time duration is 5 seconds. I told you that it will come like this because initially the flow rate is high and gradually flow rate will fall, right? Gradually flow rate will fall. Now this side is volume, this is TLC and this is RV. Okay, in the y-axis it is volume from TLC to RV and the x-axis is time from 0 to 5 seconds. Okay. Now in the time scale you take the mid part, 25% to 75%, and within this period what was the flow rate? This is your mid expiratory flow rate, or MEF 25 to 75. Okay, this is called mid expiratory flow rate. Okay. Now next parameter is FEV1 by FVC. FVC is vital capacity, forced vital capacity, right? Now say for example, in my case, from 6 liter to 1 liter, this whole procedure it takes 5 seconds, and within the first second, I have released 4 liters. Out of 5 liters, in first second, I have released 4 liters of air. So what is my FEV1? My FEV1 is 4 liters. My FEV1 is 4 liters. Okay. Now what is FEV1 by FVC? FEV1 by FVC. FEV1 is 4 liter. FVC is FVC. Vital capacity is 5 liter. Okay. So FEV1 by FVC is 4 by 5. That is 80%. 80%, right? Now this 80% FEV1 by FVC, it is normal. Okay. Okay. Now these are the static and dynamic parameters. Okay. Now before moving to pulmonary function test, you need to know the diseases which can be identified through pulmonary function test, right? Until and unless you know the diseases, there is no value in performing the pulmonary function test in the laboratory, right? Okay. The same thing is applicable in case of ECG, right? You are performing ECG, and if you don't know in which case there is ST segment elevation or ST segment depression, there is no use of learning ECG. So that is why we need to know the diseases, lung diseases. Okay, give a heading, lung diseases. We will classify lung diseases, right? হ্যাঁ আমি অ্যাকচুয়ালি আঁকতে পারলাম না, ঠিক আছে? ওটা মানে তুই তো বুঝতে পারছিস যে ফার্স্ট সেকেন্ডেই 4 লিটার্স বেরিয়ে গেল, ঠিক আছে? মানে অনেকটা স্টিপ হবে, রাইট? ফার্স্ট সেকেন্ডেই অনেকটা বেরিয়ে যাবে, রাইট? ফার্স্ট সেকেন্ডেই অনেকটা বেরিয়ে যাবে। ওকে, so lung diseases, right? Lung diseases, you divide lung diseases into three categories. We divide lung diseases into three categories. Now all the diseases we will classify, we will accommodate all the lung diseases, all the diseases of the respiratory system under same classification. This is our purpose, right? Okay. So what lung diseases you know, it is not expected from you. You are a first professional MBBS student. You know, you don't know all the diseases, but you know few diseases. Okay. What are lung diseases? Ekta duto example. Emphysema. Okay. What else? Bronchitis. Okay. What else? Asthma. Bronchial asthma. What else? Lung fibrosis. Okay. Very nice. Lung fibrosis. Lung fibrosis কখন দেখেছিলে? During COVID. Okay. During COVID-19 infection, coronavirus infection, there are people suffering from lung fibrosis, right? Okay. So there are different types of fibrosis as well. Not only it happens only in viral infection. There are other cases also where lung fibrosis happens. Okay. So lung fibrosis, bronchial asthma. What else? Silicosis. Okay. Very nice. This is occupational disease which is commonly associated with tuberculosis, TB. What else? Asbestosis. Again, an occupational health disease. Occupational disease. Anything else? Pneumonia. Okay. You should tell that pneumonia, very common, right? Pneumonia. Anything else? Lung cancer, carcinoma. Okay, very nice. So almost you are telling many diseases that affects our respiratory system, affect our lungs, right? Now we will classify the diseases. How to classify lung diseases? এখন তো আমরা randomly কিছু ডিজিজ বলে যাচ্ছি, কিন্তু সেগুলোকে কোন ক্যাটাগরিতে ফেলবো? Okay. So this is our purpose. We will classify lung diseases. So first, there will be three classification under lung diseases. Number one is obstructive lung disease. Obstructive. You write obstructive. Okay. Second is restrictive, and third is vascular. Obstructive, restrictive, and vascular. Okay. Obstructive, restrictive, and vascular. The name suggests, right? You know what now? By now you know what is obstructive. There is definitely some obstruction in the airways. Okay. Say for example, bronchial asthma. The respiratory. You know the basic anatomy of the lung, the bronchus, right? You know, all of you know. So there are 23 generations of our air pipes. 23 generation, and up to 16th generation it is conducting only, and 16th to 23rd generation they are taking part in the diffusion process, right? Oxygen carbon dioxide exchange process from 16th to 23. Okay, so all of you know the basic anatomy of lung. Now obstruction means there is some obstruction in the airway. Either the airway is narrowed, or there is hypersecretion within the respiratory tract, or there may be foreign body. So basically there is obstruction. So that is why there is respiratory distress, right? So basic point is obstruction anywhere in the respiratory tract, right? Anywhere in the respiratory tract. Okay. Now second is restriction. Can you give me an example of restriction? Okay. First obstruction. What are the lung diseases that you told? तुमरा जो आप लोगों ने जो बताया है कि क्या diseases जो बताया है? COPD. Okay. What else under obstruction? Emphysema. Okay. Very nice. Emphysema is an obstructive lung disease. Yes. Bronchial asthma. Very nice. Bronchial asthma is an obstructive respiratory disease. Right. Okay. Now come to restriction. I will I'll give you example of all the diseases. Right. So now restriction. Give an example of restriction. Restriction. Any example of lung disease? Like silicosis, asbestosis. Why are you calling it restriction? Air ঢুকতে পারছে না। Air ঢুকতে না পারলে তো obstruction. Lungটা expand করতে পারছে না। Okay. So restriction means some part of the lung is non-functional. Okay, it may be a lobe, it may be a lobule, right? Or it may be one half of the lung, right? Completely, it is not working at all. Take a very simple example. Take a very simple example of pneumonectomy. What is pneumonectomy? Pneumonectomy মানে lung কেটে বাদ দেওয়া। ঠিক আছে, পুরোটা নয়, definitely some part. মনে করো কোনো একটা লাংসের any lobe of the lung there is a there is a tumor or bronchogenic carcinoma or cancer, lung cancer. So, one half of the lung has been removed, pneumonectomy, to save the patient's life, right? Now, the patient is with one lung. It is a restriction. It is a restriction, right? So, pneumonectomy is a restriction. Another example, fibrosis. One part of lung is fibrosed. There are no alveoli. It is completely replaced by fibrous tissue. So, that lung is not at all a lung now. It is fibrous. It is fibrous tissue. It is not taking part in diffusion. Okay, it is not taking part in carbon dioxide and oxygen exchange. So, fibrosis, restriction. Okay. Now, another sort of restriction. See, another sort of restriction. If I compress his chest from behind and from front, what will happen? He will not be able to expand his lung. Okay, this was the process of punishment in earlier days. Okay, so you do chest compression from all the sides, patient will not be able to take air in and out, right? And ultimately the subject will die, right? Okay, so same thing can happen. Same thing can happen. You think of restriction from outside. Okay, your lung wants to expand and you are not allowing the lung to expand. What will happen, right? So this may happen. Okay, so restriction may come from inside, restriction may come from outside. I will explain. Okay, so before that, write the examples of obstructive lung diseases. Number 1, bronchial asthma. Number 2, chronic bronchitis. Number 3, emphysema. Number 4, bronchiectasis. Bronchiectasis. Number 5, bronchiolitis obliterans. Right? Right. Again, I am repeating: bronchial asthma, chronic bronchitis, emphysema, bronchiectasis. Bronchiectasis, right? I am writing. Bronchiectasis, then bronchiolitis obliterans. Bronchiolitis obliterans. I will explain all the diseases because it is not a pathology or medicine class, so I will not explain all the diseases in detail, but very basic pathophysiology you need to know, as because you are going to perform pulmonary function test, right? I will not explain bronchial asthma in detail, how bronchial asthma happens, what are the signs and symptoms of bronchial asthma, what is the pathology of bronchial asthma, how to treat the patient of bronchial asthma. We'll not talk about these things right now because this is not a class of pathology, not a class of medicine, right? Okay, but you need to know bronchial asthma a little bit, its origin, how does it happen, right? You need to know the basic deviation from physiology. Okay, how physiology becomes a pathology, right? So this is the pathophysiology. You need to know basic points for chronic bronchitis, for bronchial asthma, for emphysema, right? You need to know a little bit, right? No details of bronchial asthma or COPD will be asked at your level at first professional MBBS, right? You will get to know details, pathology of all the diseases in second professional MBBS under pathology, okay? And in medicine, you will study how to treat them and how to diagnose them. Here also you will get to know how to diagnose them, okay? So bronchiectasis, and last is bronchiolitis obliterans, okay? You have written the major, there are many others as well, right? What I am telling is only the major diagnosis under obstructive lung disease, okay? So whenever you will sit in your clinic or OPD or hospital, you will see commonest patients within this obstructive lung diseases, right? Okay, now restrictive lung diseases. As I told, restriction may come from inside, restriction may come from outside, okay? So if I compress lung, चारों तरफ से मैं, if I compress my lung, I will not be able to ventilate, right? I will not be able to ventilate. So this is restriction from outside, okay? And if you remove one lung, and if you have fibrosis, pulmonary fibrosis, right? So it is a case of internal restriction. So some problem is inside the lung. That is why there is restriction, right? Some problem is within the lung. That is why there is restriction. So we call it intraparenchymal restriction. So restrictive lung disease, you divide it into two. One is intraparenchymal restriction and another is extraparenchymal restriction. Okay? Intraparenchymal restriction and extraparenchymal restriction. Parenchyma means lung tissue, right? Parenchyma means lung tissue. So any problem within the lung tissue, that is why the patient is having restrictive lung disease. We call it intraparenchymal restriction. Okay, under intraparenchymal restriction you write number 1 IPF or idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis or pulmonary fibrosis simply you can write. Okay, idiopathic pulmonary fibrosis matlab something is happening within the lung, that is why there is restriction. Okay, there is no external restriction, but from inside the lung there is restriction. Okay, number 1 is idiopathic pulmonary fibrosis, number 2 is pneumonectomy. Okay, number 3 is occupational lung disease like silicosis, like asbestosis, right? Number 4 is pneumonic consolidation or pneumonia. So these are all internal restriction or intraparenchymal restriction. Internal restriction or intraparenchymal restriction. Okay. Now extraparenchymal restriction. There is some restriction from outside. Lung is okay. Lung is completely okay. There is no problem within the lung, but someone is not allowing lung to expand. Okay. Someone is not allowing lung to expand. Who does usually allow lung to expand? Yes, the muscle, the nerves and the chest wall, bony thoracic cage, right? Okay. So there might be some problem within the bone or within the neuromuscular system. Okay. So your lung can expand, but your diaphragm is not allowing. During inspiration, what are the inspiratory muscles? Tell me, what are the inspiratory muscles? What are the inspiratory muscles? Number 1 is diaphragm. Number 2 is external intercostal. External intercostal. What will happen if diaphragm is paralyzed? If your intercostal muscles are paralyzed, what will happen? Patient will not be able to breathe. Okay. Patient will not be able to breathe. And this is a case of neuromuscular paralysis that happens in myasthenia gravis. People of myasthenia gravis die with this. Okay. If you do not ventilate the patient on a ventilator, immediately the patient will die due to respiratory failure, right? Okay. So it is a restriction. Again think of another sort of restriction. Another sort of restriction is the bony problem. Bony problem. All this the bucket handle movement, okay, and what pump handle movement, bucket movement, right? Your chest wall moves in this direction, right? Your chest wall moves and your chest wall expands along with lung, right? Only if chest wall allows the lung to expand, lung can expand, right? So there is some problem within the bone. Okay, there is some problem within the bone. Bone में problem है. Now bone में क्या problem हो सकता है? Kyphosis, scoliosis, ankylosing spondylitis. Okay, right. Okay, now divide. Okay, first you need to divide. So extraparenchymal restriction, you divide it into 3. One is neuromuscular restriction, another is bony restriction, and another is pleura. Okay, under extraparenchymal restriction, you write neuromuscular restriction, bony restriction, and pleura. Under neuromuscular restriction, you write myasthenia gravis, you write Lambert-Eaton syndrome. You know what is Lambert-Eaton syndrome? What is myasthenia gravis? It is under nerve muscle physiology, right? Okay. In both the cases, there is neurological paralysis, NM junction problem, neuromuscular junction problem. Okay. So under myasthenia gravis and Lambert-Eaton syndrome, LE syndrome, Lambert-Eaton syndrome. This is given in your physiology book. Okay, I will not explain because this is not a class of myasthenia gravis or Lambert-Eaton syndrome, right? And under bony restriction, you write AS. AS is ankylosing spondylitis. Okay, AS, then kyphosis, then scoliosis. Okay, all these diseases will not allow the lung to expand. Okay, kyphosis, scoliosis जानो तो? What is kyphosis? पता है? Kyphosis क्या है? Scoliosis क्या है? Okay, kyphosis is spine, anterior bending of the spine, and scoliosis is lateral bending of the spine, right? Lateral bending of the spine. Okay. So kyphosis, scoliosis, usually combined होता है kyphosis, scoliosis, kyphoscoliosis. Okay. In the same patient, you can see kyphosis and also scoliosis, kyphoscoliosis. So what happens, the thoracic cage shape is not resilient. It will not allow the lung to expand. So this is why the patient with kyphosis, they will have symptoms of respiratory distress, right? Okay. So neuromuscular restriction, myasthenia gravis, Lambert-Eaton syndrome, and also under neuromuscular you can write under neuromuscular, you can write sleep apnea syndrome. Okay. Sleep apnea syndrome, obesity, very much obesity. The BMI more than 30-35, it happens. Okay. শ্বাসকষ্ট হয়, খুব মোটা লোকেদের শ্বাসকষ্ট হয় কেন? This is obstructive sleep apnea, right? Okay, we'll again talk about obstructive sleep apnea, obesity detail in sequence of respiratory system classes, right? Okay. And the control system of respiration, it comes from medulla. There are different groups of neuron, VRG, DRG, right? Ventral respiratory group, dorsal respiratory group. They drive our inspiration and expiration. If these neurons are not working, again there will be restrictions. Okay. So restrictive lung disease, we have divided into intraparenchymal and extraparenchymal. Okay. Intraparenchymal, we have given examples of few diseases. Under extraparenchymal, we have divided into bony restriction, neuromuscular restriction, and pleura. Under bony restriction, we have ankylosing spondylitis, we have kyphosis and scoliosis. Under neuromuscular restriction, we have myasthenia gravis, we have Lambert-Eaton syndrome, we have morbid obesity, we have obstructive sleep apnea syndrome, right? And under pleura, you have pleural effusion, okay, pleural effusion, pneumothorax, right? So all these things are under pleura. Okay, we know what is pleural effusion. Okay, accumulation of fluid within the pleural space. Yes. So again, it is a restriction. Okay, the thing is, you have known the lung parameters, static and dynamic parameters. You have known what are the tests included under pulmonary function test, and you have classified lung diseases. Now, with the help of spirometry, you need to differentiate. Between an obstructive lung disease and restrictive lung disease. Your first target is to differentiate. Okay. Another sort of lung disease, vascular lung disease. Okay, vascular lung disease. Can you give me an example of vascular lung disease? There is nothing to do with the lung parenchyma. There is no problem in the lung parenchyma, but there is problem in the blood vessels that are supplying and draining lungs. So pulmonary circulation is affected. Can you give me one example? Simple pulmonary hypertension. Angina pectoris is a disease of heart. Okay. So the problem is within the pulmonary vasculature. So write two examples. One is pulmonary hypertension and another is pulmonary thromboembolism. You know what is thromboembolism? Yes, thrombus formation, and it is dislodged into the pulmonary circulation. We call it thromboembolism. Thrombus formation within the circulation, and it will dislodge and जाके फंस जाता है मतलब pulmonary circulation में, ठीक है? It is dislodged into the pulmonary circulation. Okay. So write two diagnoses under vascular lung disease, and you remember vascular lung diseases is not required for us right now, because vascular lung diseases we do not diagnose with a spirometry. For vascular lung disease we need angiography and we need ETCO2. These are the investigations which are used to diagnose vascular lung diseases. With the help of spirometry, DLCO, we do not use vascular lung diseases. With the help of spirometry, with BDR, DLCO, we just classify restrictive and obstructive diseases. Okay, so for your level, if your examiner asks you classify lung diseases, if you simply say, sir, lung diseases are of two types, one is obstructive and another is restrictive, that is okay for you, even if you do not mention vascular lung diseases, right? Okay, but I have given you the complete classification for your better understanding. Okay, now first thing is, take a patient of respiratory distress and you have identified that this is a case of respiratory system and not a cardiovascular system. once you are confirmed that it is a case of respiratory system and not cardiovascular system, and you are performing PFT or pulmonary function test, and under pulmonary function test you are doing the major investigation, which is spirometry with BDR. Okay, and that instrument is over there in the PFT room. In next class I will take you to the PFT room and we will perform PFT on a patient, not on a patient, because here we will not be having any patient. Okay, if there is any patient on that day, patients usually come there for PFT, but it doesn't happen every day, right? So if we get patient, I will show you on a patient, and if patient is not available, we will perform PFT within us, right? Okay, any student volunteer, right? Okay, we will perform PFT. Okay, so it is a very simple machine. So there is a device called mouthpiece, right? So patient will hold it and blow air into the device, and the device is connected with a USB cable to the computer, and in the computer there is a pulmonary function test software, and the software will analysis all the volume of air, the PEFR, MEFR, FEV1, FEV1 by FVC. The machine will calculate everything, right? So this is the thing. I will show you the machine and we will perform spirometry in next class, that's PFT part 2. Okay, but today what we are discussing is the basic knowledge, the background knowledge required to perform PFT. Okay, मैं आज ही आपको ले जा सकता था वहाँ PFT lab में, but there is no use until and unless you know the background knowledge. There is no use of using the PFT machine, right? Okay, so a little bit of background knowledge is remaining, right? So our first target is to differentiate. Lung disease into the category. Okay, आपको at first sight आपको कोई diagnosis करने के लिए नहीं बोल रहा है कि ये bronchial asthma है, कि COPD है, whatever कुछ भी है, ठीक है, नहीं बोल रहा है. First आपको identify obstructive lung disease or restrictive lung disease. Okay, that is basic knowledge at first year MBBS. Basic knowledge. If you cannot identify a case as obstructive or restrictive, there is definitely some problem, right? आपको this is your basic competency knowledge, right? आपको identify करना ही है. If you cannot tell it is a bronchitis or bronchial asthma or emphysema, nobody will scold you. There is no problem, absolutely no problem. But what is must for you is to categorize that it is obstructive and it is restrictive. Okay, so after performing spirometry, we can identify whether it is obstructive case or restrictive case by seeing the parameters. The machine will tell you, right? Seeing the parameters, and also by seeing a flow volume loop. Okay, I will explain the flow volume loop in subsequent class, but today we will discuss how to categorize a case as obstructive or restrictive with the help of lung parameters. Okay, and you know, static parameters will not help you. The static parameters, the RV, TLC, they will not help you. Okay, in diagnosing, usually they will not help you in diagnosing obstructive or restrictive. Okay, few cases will help. If you look at TLC, TLC is very high in emphysema. Okay, TLC is very high in emphysema. Residual volume is also high in emphysema. Vital capacity will be reduced in both obstructive and restrictive, right? Okay, so what parameter you need to see first in a PFT report? Okay, one another important point, during ECG also I told you the same thing. Okay, usually in most of the laboratories, ECG or any electrical investigation like nerve conduction study or EEG, okay, everything is done by a technologist, a medical technician. It is usually not done by a doctor, right? Usually not done by a doctor, and also PFT usually not done by a doctor. Okay, a technologist will do this, and they will provide you the paper, the graphs, the data, and you need to report it as a physician. Okay, but every time I tell, that doesn't mean you will not learn how to perform it, the test, right? It doesn't mean that you will not learn how to perform a PFT, how to perform ECG, how to perform nerve conduction study, how to perform electroencephalography, right? Okay, you should know, because until and unless you know, if your technologist does some mistake or whoever is testing does some mistake, you will not be able to identify. And in few cases, in in emergency situation, you may need to perform ECG, right? When the technologist is not there, right? So never say that I will not learn. It is a job of a technologist. He will do it for you, for me. No, absolutely no. You should learn how to perform PFT, how to perform ECG, right? And everything. Where to attach the ECG clips, where to attach the leads for electroencephalography, right? You need to know. Okay, okay? Clear, everyone? Okay. Still, performance is not in your syllabus. Okay, National Medical Commission doesn't want you to perform the test, but you need to interpret. You need to know the interpret. You need to know the interpretation of the graphs for ECG, for PFT, for nerve conduction study, and in subsequent whatever test you will be going through, right? So in your first professional MBBS examination also, we will provide you the report, okay, and you need to interpret, right? We will provide you the data which is coming from PFT machine, okay, the graph, the data, and you will need to identify whether it is the case of obstructive disease and restrictive disease. If it is the obstructive disease, whether it is bronchial asthma or COPD, right? But the very basic knowledge for you, the must know knowledge for you is to identify between obstructive disease and differentiate between obstructive disease and restrictive disease, okay? So if I place a report in front of you, okay, a pulmonary function test report in front of you, first what parameter you need to look for? So the first parameter you will look for is the FEV1 by FVC, the dynamic parameter FEV1 by FVC, right? FEV1 by FVC. Okay, so you write the diagnostic algorithm, okay, diagnostic algorithm. So take a case of lung patient, give a heading lung patient, a vertical arrow. So from lung patient, a vertical arrow, and just by the side of the arrow you write FEV1 by FVC, okay. So you are taking a lung patient, arrow. Always during examination you use flow chart. Do not write any paragraph. Nobody will go through. So lung patient, you are doing FEV1 FVC. Now divide it into two, more than is equal to 80% and less than 80%. Okay, more than is equal to 80% and less than 80%. Okay, now under more than 80%, you write normal or restrictive. Normal or restrictive. And under less than 80%, you write obstructive. Okay, so this is the easiest way to categorize a patient as obstructive or restrictive. Getting my point? पहले मैं की देखूँ. What you are going to check? You are going to check FEV1 by FVC. अगर ये 80% से ऊपर है, 80% है या फिर 80% से ऊपर है, then normal. Okay, or it may be restrictive as well, right? So once it is more than 80%, you cannot differentiate whether it is restrictive or normal, but at least you can say that it is not obstructive, right? But once FEV1 by FVC is less than 80%, you just put a stamp, it is obstructive patient. Okay, why do we need to differentiate between obstructive and restrictive? Because treatment is different. Treatment is different for both the cases. You will treat a fibrosis cases differently and you will treat a bronchial asthma case differently, right? Okay, because treatment protocol is different. This is why you need to differentiate. You need to categorize the patient. We will treat obstructive patient in a separate way and restrictive patient in a separate way, right? So the first parameter you will look for is FEV1 by FVC. Once FEV1 by FVC is less than 80%, it is obstructive. Means it may be bronchial asthma, it may be COPD, it may be emphysema, it may be chronic bronchitis, it may be bronchiectasis, it may be bronchiolitis obliterans, whatever. But it is obstructive. I don't know what, but it is obstructive. Okay? And if it is more than 80% or 80%, it is either normal or restrictive. Okay? Right. Now, अब restrictive में बहुत कुछ है. That I will explain in the PFT room in next class. ठीक है. So restrictive में जो diagnostic algorithm that will be expanded more and more, branching and branching. So take the obstructive patient. Take the obstructive patient. Okay. In the clinic, the most common obstructive patient we find is COPD and bronchial asthma. Okay. So both are obstructive disease. COPD and bronchial asthma, both are obstructive disease, but again there is little difference in their treatment, in their management, right? In their management. So from history we get some points, because bronchial asthma patient, there will be history of allergy, right? There will be history of allergy. Mostly the patients will be children, right? And usually there is no history of smoking, right? But in case of COPD, under COPD we have two different diagnoses. Under COPD we have two different diagnoses. One is bronchitis, chronic bronchitis. Another is emphysema. Okay. Now, as आपका FEV1 by FVC is less than 80%, आपको पता चल गया कि the case is obstructive disease. But आपको ये नहीं पता है कि ये bronchial asthma है, कि bronchitis है, कि emphysema है. ठीक है. अब आपको ये evidence करना पड़ेगा. Although from history आपको थोड़ा पता है, because if the patient is having allergy history, it is going in favor of bronchial asthma. If there is history of smoking, it will be going in favor of chronic bronchitis, or it may be going in favor of emphysema, right? Okay. Now you need to prove that it is bronchial asthma or it is COPD. Okay. So for proving this, you need to perform the BDR. You remember under pulmonary function test, the first test you have written is spirometry with BDR, bronchodilator reversibility. Okay. So what is bronchodilator? Bronchodilator means it is a drug. It is a drug, or it is a medicine. It is a drug which is given in the form of inhalation. Okay. Have you seen inhaler using? Okay. So you have, all of you know what is inhaler, and people with respiratory distress, they use inhaler, right? Okay. So there is a drug called bronchodilator. Okay. An example is salbutamol. Okay, salbutamol. It is marketed under the brand name Asthalin. Okay, Asthalin inhaler. The composition is salbutamol. Salbutamol is beta-2 agonist. Okay, where the drug is applied within the respiratory tract, the bronchial smooth muscles relaxes. Okay, as a result they dilate. Okay, so air entry passage is easier now. Okay, if you give that pump, that inhaler to the patient, okay, there will be bronchodilation. Okay, there will be bronchodilation. All the respiratory pipes will be dilated. Initially they were narrowed. Okay, they will dilate. Okay, now air entry in and out, it will be easier, and the patient will have relief, right? Okay, so once FEV1 by FVC is less than 80%, तो आपको क्या करना है? पेशेंट को एक ब्रोंकोडाइलेटर देना है, सल्बुटामोल, 2 puff. Okay, 1, 2. Okay, 2 puff inhaler अपने पेशेंट को दे दिया. Now wait for 5 minutes. Wait for 5 minutes and you again perform spirometry. Okay, again perform spirometry. So under obstructive you have written less than 80%, you have written obstructive, right? Okay, now give an arrow, and beside the arrow, down arrow, and beside the arrow you write BDR. BDR means bronchodilator reversibility. Okay, bronchodilator reversibility. Within bracket you can write salbutamol inhalation 2 puff. Okay, or 2 puff salbutamol inhalation. So take a case. Until and unless you take a case, you will not be able to understand. So take a case. Say for example, in our case, we have a patient of respiratory distress, and we have performed spirometry, and we have got what? FEV1 by FVC. FEV1 by FVC is 60%. So it is a case of obstructive lung disease. It is a case of obstructive lung disease. Now मैंने क्या किया? इसको 2 puff salbutamol inhalation दिया है. Wait for 5 minutes and again perform the test. Now you will look for increment in FEV1 by FVC. You will look for increment in FEV1 by FVC. FEV1 by FVC मतलब कितना बढ़ गया पहले से, ठीक है? FEV1 increase in FEV1 by FVC. If it is now arrow divide it into 2. BDR लिखा है अपने arrow के बगल में, right? And divide it into 2. Okay. In one side you write FEV1 by FVC increment by more than 12%. FEV1 by FVC increment by more than equal to 12%. FEV1 by FVC increment by more than is equal to 12%. Okay, and another less than 12%. FEV1 by FVC increment by less than 12%. ठीक है? FEV1 by FVC increment less than 12%. So in our case it was 60%, right? In our case it was 60%. So say for example after salbutamol inhalation 5 मिनट के बाद आपने फिर PFT किया, फिर spirometry किया and आपने देखा कि FEV1 by FVC is now 75%. So how much is the increment? 15%. So it will be going in favor of bronchial asthma. ठीक है? So more than 12% increment in FEV1 by FVC, you write an arrow and write bronchial asthma. Okay, and less than 12% increment, say for example 60% से 67% हुआ है, ठीक है? It is a case of COPD. COPD means either emphysema or bronchitis. ठीक है? अच्छा, now the question is why there is increment or improvement in FEV1, significant improvement in FEV1 by FVC after bronchodilator inhalation only in case of bronchial asthma and not in a case of COPD. Why? You don't know this because you do not know the pathophysiology, right? Okay, now little bit pathophysiology of bronchial asthma and COPD. Bronchial asthma क्यों होता है? क्यों होता है bronchial asthma? Allergic reaction. Okay. So bronchial asthma, I will not tell in detail because it is dealt under pathology, but you need to know a little bit right now. Okay, bronchial asthma is usually an allergic condition seen usually in childhood, which is characterized by hyper responsiveness of bronchial smooth muscles and inflammation. Okay, characterized by hyper responsiveness of bronchial smooth muscles and inflammation. Right, this is bronchial asthma. Hyper responsiveness of bronchial smooth muscle, it means that bronchial smooth muscles are contracting more, right? Smooth muscle, you know what is smooth muscle, right? So bronchial smooth muscle are contracting more, right? Now anyhow you need to apply a drug so that bronchial smooth muscle relaxes, right? So similarly you give salbutamol to the patient and there will be relief, right? So this is how bronchial asthma works. Now what is happening in case of COPD? In COPD pathology is different. In COPD there are two different diseases. One is chronic bronchitis and one is emphysema. Okay. So what is the mode of obstruction in chronic bronchitis? There is hypersecretion of mucus gland, within the respiratory tract. So more mucus secretion. Okay, there is obstruction in bronchial asthma, there is obstruction in bronchitis, but the mode of obstruction is different. In bronchial asthma, mode of obstruction is bronchial smooth muscle contraction, and in bronchitis, the mode of obstruction is hypersecretion of mucus. Mucus জমে গেছে respiratory tract এর ভেতরে, ঠিক আছে? Within the respiratory tract there is mucus and there is problem in air passage in and out. Okay, mucus secretion. And what is happening in emphysema? Emphysema is of two different types, right? Emphysema. Okay, emphysema, two different types. One is centriacinar emphysema, another is pan-acinar. You know what is acini? Lungs হয়েছে ডিসেকশনে লাং কেটেছিস অ্যানাটমিতে? ওকে, ঠিক আছে। Okay, so centriacinar emphysema and pan-acinar emphysema. Okay, centriacinar emphysema and pan-acinar emphysema. Centriacinar emphysema, it is seen in smokers. Okay, emphysema কেন হয় আগে বলতো? emphysema কেন হয়? সেপ্টা। ওকে, অ্যালভিওলি গুলো কি রকম আছে? অ্যালভিওলি গুলো এরকম আছে তো? এরকম অনেক অ্যালভিওলি আছে, right? So there are multiple alveoli, right? And there are common wall between two alveoli, right? এখানে একটা alveoli হলে এখানে একটা alveoli আছে, there is a common wall, right? যেমন এই ঘরটা আর ওই ঘরটা দুটোর common wall রয়েছে এটা, ঠিক আছে? Now what will happen if I destroy this common wall? একটাই বড় ঘর হয়ে যাবে, তাই তো? So if the common wall is destroyed, okay, কি অসুবিধা হবে common wallটা যদি destroy হয়ে যায়, একটাই বড় alveoli হয়ে যাবে। But the problem is the surface area for diffusion is decreased now. Surface area তো অনেক কমে যাবে, তাই তো? মাঝখানের ওয়ালগুলো যদি সরিয়ে দিই surface area তো অনেক কমে যাবে, right? So surface area will decrease, okay? তাহলে surface areaটা আমার লাগবে কেন? Because diffusion takes place there, okay? So diffusion barrier is lost, okay? Diffusion barrier is lost. This is emphysema. Now once it affects pan acini, we call it pan acinar emphysema. Once it happens in centri-acinar region, we call it centri-acinar emphysema. Centri-acinar emphysema is associated with smoking, যারা smoking করে তাদের হয়, ঠিক আছে? And it affects the apex of the lung, okay? You remember smoke উপরে ওঠে, ধোঁয়া উপরে ওঠে, so apex of the lung is affected, right? And pan acinar emphysema, it usually affects the lower lobe, pan acinar emphysema, and the cause of pan acinar emphysema is, you know, alpha 1 antitrypsin deficiency. জানা আছে? Have you heard the name alpha 1 antitrypsin? Alpha 1 antitrypsin deficiency causes emphysema. Alpha 1 is a genetic disorder. So alpha 1 antitrypsin. This is why COPD patients. If you go to the OPD from second year onwards, you will go to OPDs, right? And you will see COPD patients in female. But in India, in West Bengal, hardly any female smokes, right? So still you will get emphysema patient because those cases might be alpha 1 antitrypsin deficiency, right? So COPD patient money is smoker, not necessarily. COPD can happen in non-smokers as well, in females as well, right? In Western countries, female smoke, but in India hardly female smoke, right? Okay. So centri-acinar emphysema, pan-acinar emphysema. Centri-acinar emphysema is associated with smoking. Affected zone is upper lobe of the lung, and pan-acinar emphysema, it is affected lobe is lower lobe, and it is due to alpha 1 antitrypsin deficiency. Okay, trypsin. What is function of trypsin? Digest. Okay, so এই যে alveolar septa গুলো আছে ওর মধ্যে প্রোটিন আছে, কোলাজেন আছে, ঠিক আছে? trypsin কি করে? trypsin ওগুলোকে ডাইজেস্ট করে দেয়। Now there is an antitrypsin जो trypsin को रोकता है। Now trypsin को रोकने वाला antitrypsin नहीं है, so alpha 1 antitrypsin deficiency, right? trypsin को रोकने वाला antitrypsin नहीं है, alpha 1 antitrypsin deficiency, so it will cause emphysema. It will destroy all the alveolar septa, right? And it will cause emphysema, correct? Okay, so study this much. आज अगर इससे ज़्यादा बताऊँ तो ऊपर से जाएगा।
So today we'll see the viscera of stomach, okay? So stomach is the dilated portion of the alimentary canal. This part is the stomach. It is situated in the upper part of the abdomen, extending from beneath the left costal margin region into the epigastric and umbilical region. In this part, left costal margin, epigastric and umbilical region. This is the extent of the stomach. Much of the stomach lies under cover of the lower ribs, okay? And the stomach is relatively fixed at both ends. That means near the cardiac end and near the pyloric end, it is fixed. But it is very much mobile in between. This part is mobile and it gets distended during eating food or any liquid, okay? So now anatomical description of the stomach. Shape is roughly J-shaped structure, okay? You can see stomach has two openings. A silence, don't talk among yourselves. Two openings, the cardiac opening and pyloric orifices. So this is the cardiac opening and this here lies the pyloric orifice. Here you can see this is the pyloric orifice. Okay. It has two curvatures. All are two curvature, two surface, two opening. Two curvatures are greater and lesser curvature. This larger one is the greater curvature and this one is the lesser curvature, two curvatures. Two surfaces are the anterior and posterior surface, okay? Or you can say antero-superior surface and postero-inferior surface, okay? So this is antero-superior surface, and on the posterior aspect you will see the posterior surface. And these are the presenting parts of the stomach. Stomach is divided into these following parts. Fundus, here above the line, transverse line passing through the cardiac end. This part, distended part is the fundus. From the cardiac orifice up to this incisura angularis, this region is the body of the stomach. Okay, and then this part is the pyloric antrum. After that, pylorus. Pylorus means pyloric sphincter, thickened circular muscle layer, and pyloric canal. This part is the canal, okay, through which food passes from stomach to the first part of the duodenum. Okay, so these are four parts you have to say: fundus, body, pyloric antrum, and pylorus. So we will discuss individual parts. Stomach is divided into fundus, which is a dome separate. Which part is fundus? It is asked. How will you differentiate between body and fundus? The line. Okay. It is a dome separate and projects upward and to the left of the cardiac orifice, usually full of gas. Okay. Body, it extends from the level of cardiac orifice to the level of the incisura angularis, a constant notch in the lower part of the lesser curvature. Incisura angularis lies in the lesser curvature. Okay, you have to show this incisura. Next is pyloric antrum, extends from the incisura angularis to the pylorus. Then pylorus, it is most tubular part of the stomach, and the thick muscular wall is called the pyloric sphincter, and the cavity of the pylorus is the pyloric canal. Okay. Okay, so see in this picture, this part is fundus above the cardiac orifice. Then this part is body up to the incisura angularis. Then pyloric antrum. This part is antrum. Okay, up to in this part, in between the antrum and pylorus, here crosses the prepyloric vein of Mayo. Okay, you have learned during the blood supply, differentiate between the pyloric antrum and pylorus. So pylorus consists of pyloric sphincter and pyloric canal. See here, this is thickened part, this is forming the sphincter, and this narrow channel in between the passing through the sphincter is the pyloric canal. Okay, and these are the gastric rugae. Rugae means longitudinal fold. Stomach has been cut longitudinally. Okay, longitudinal folds are present in empty stomach. These are known as gastric rugae, and rugae becomes absent during distension of the stomach. Okay, understood? Here the muscle layers has been shown. Outermost is the longitudinal muscle layer. Here is the longitudinal muscle layer. Then there is circular muscle layer. See, these are forming the circular muscle layer. And innermost is oblique muscle layer. So the muscular layer of stomach, three muscle layers are present. Outermost longitudinal, middle circular, innermost oblique. Okay, you have drawn in your histology. কি এঁকেছিস তো stomach? Okay, now we will discuss the two curvatures. Lesser curvature, it forms the right border of the stomach and extends from the cardiac orifice to the pylorus. It is suspended from the liver by the lesser omentum. Okay, so lesser omentum is attached along the lesser curvature. Then greater curvature, much longer than the lesser curvature, extends from the left of the cardiac orifice over the dome of the fundus and along the left border of the stomach to the pylorus. Okay, this is the extent of greater curvature. These ligaments are attached to the greater curvature. See, first is gastrosplenic ligament or gastrosplenic omentum. It extends from the upper part of the greater curvature to the spleen. Gastrosplenic means connecting the stomach with the spleen. Another one is present, gastrophrenic ligament, that is connecting the stomach to the diaphragm. Gastrophrenic, phrenic means diaphragm. Okay, and there is most of the extent greater omentum. The greater omentum extends from the lower part of the greater curvature to the transverse colon. Okay, and peritoneum completely surrounds the stomach. Understood? Next, আচ্ছা এই দুটো লাইটের সুইচ কোথায়? এখানে? বন্ধ হয় না? ওকে, ঠিক আছে, তাহলে বুঝতে পেরেছিস greater and lesser curvature and their attachment. Okay, next, see, this one is the along the lesser curvature, lesser omentum is attached. Okay, and two gastric arteries are lying along the curvature. This is greater curvature. Here is attachment of gastrosplenic ligament. This is the greater omentum, and here will be the attachment of gastrophrenic ligament. Okay, which is also a peritoneal reflection connecting stomach with the diaphragm. Okay. Okay. See here the attachment of greater omentum. Two layers of, here this is a longitudinal section through our abdomen. Okay, so this is liver, this is stomach, this is transverse colon, this is jejunum. Okay, and retroperitoneally here lies the duodenum, here is the pancreas. Okay, so this is lesser omentum, and this part is forming the lesser sac, and this outer whole part is forming the greater sac. Okay, so these four layers of peritoneum together forming the greater omentum, and this is lesser omentum connecting the stomach with the liver. Okay, and this outer two layer, first layer and fourth layer, is formed by the peritoneum of the greater sac, and second and third layer is formed by the peritoneum of the lesser sac, and these layers are gradually fused with each other. Okay, you cannot separate in a adult. Obliterated mainly, and terminal end is attached to the transverse colon. Okay, understood? Now two openings of the stomach. First is cardiac orifice, where the esophagus enters the stomach, and the pyloric orifice, it is formed by the pyloric canal, which is about 1 inch in length, that is 2.5 centimeter long, and the circular muscle coat of the stomach is much thicker here and forms the anatomic and physiologic pyloric sphincter. Okay, pyloric orifice, near the pyloric orifice lies the pyloric sphincter. Here is the sphincter. Next, we will discuss the wall of the stomach, different layers. That means histological feature. Okay, so outermost is serosa. Serosa consisting of layers of connective tissue, loose areolar connective tissue, which is continuous with the peritoneum, mainly peritoneal covering. Okay, that is forming the serosa. Antero-superior surface is covered by peritoneum of greater sac. Posterior-inferior surface is covered by peritoneum of the lesser sac. Okay. Now, muscular wall. Muscular wall of the stomach, it contains three muscle layers. Okay. Outermost longitudinal fibers, then middle circular fibers, innermost oblique fibers. These are the three muscular layers. Then mucous membrane. Mucous membrane is thrown into numerous folds or rugae. So these are the rugae or numerous folds, and that are mainly longitudinal in direction. Okay. In case of ulcer formation or in case of any cancer of the stomach, these folds disappear in the region where the ulcer or cancerous tissue are present. Okay. So these folds are, that's why important, and the folds flatten out when the stomach is distended. Now relations of the stomach. Relations is important. Okay? Mainly this posterior relation. This is forming the stomach bed. Stomach bed comes as a short note. Okay. To practice this schematic diagram and remember this structure. First you see the anterior relations. Anterior relations of the stomach. Anterior abdominal wall, left costal margin, left pleura and lung, diaphragm, and the left lobe of the liver. All these are lying anterior to the stomach. কে কথা বলছিস এত কিসের গল্প? বাইরে গিয়ে গল্প করে আয়। না ক্লাস করতে হলে বেরিয়ে যা চুপচাপ, ডিস্টার্ব করবি না এবার, রোজ দিন বলতে হয়। So these structures are forming anterior relations of the stomach. Then posterior relation, posterior to the stomach lies the lesser sac. Then diaphragm, spleen, see here is the location of diaphragm forming dome above this fundus of the stomach. Diaphragm, spleen, here is the spleen, left suprarenal gland, this one is suprarenal gland, left kidney, upper part of left kidney, splenic artery, this is tortuous splenic artery lying along the upper margin of the pancreas. Then pancreas, transverse colon and transverse mesocolon. Okay, so all these structures are forming the stomach bed or posterior relations of the stomach. Diaphragm, spleen, left suprarenal gland, left kidney, splenic artery, this pancreas, then transverse colon and transverse mesocolon. Okay, so you can remember with a mnemonic, Dr. A said kills patient cruelly and mercilessly. Okay, so Dr. D represents the diaphragm, S is spleen, Sen is left suprarenal gland, kills, K is kidney, cruelly, and S also includes this splenic artery. Okay, patient is pancreas, then cruelly and mercilessly, cruelly is colon, mercilessly is mesocolon. Okay, transverse colon, transverse mesocolon. Okay, so all these structures you have to remember. Okay, stomach bed. Mnemonic is Dr. A Sen, S X নয়, S PQRS, kills patient, kills, K kidney হচ্ছে, patient's P is pancreas, cruelly and mercilessly. Cruelly C for colon and mercilessly M for is mesocolon. D for diaphragm, S is suprarenal gland, Sen is spleen and splenic artery. Spleen and splenic artery both. Okay. Okay, understood all these structures you have seen and practice this diagram. I'm showing it. This diagram, okay? Diaphragm, spleen, splenic artery, left suprarenal gland, left kidney, pancreas, transverse mesocolon and transverse colon. Okay, all these structures are forming the stomach bed, and this is the outline of the stomach, this dotted line. Okay, practice this diagram. Stomach bed comes as a short note, and also asked in Viva if stomach is kept asked in viscera. Okay, বুঝতে পেরেছিস তো? হ্যাঁ, স্টমাক বেড which structures are forming stomach bed, like you will be asked. Okay, stomach is lying over these structures, that's why these structures are forming the stomach bed. Okay, now see, those structures have been shown in section. See, this is diaphragm, dome of the diaphragm. Here is the kidney. Okay, this is spleen, splenic artery. This is stomach, lesser sac. Okay, and those ligaments. Okay, gastrosplenic and lianorenal. And here is the right free margin of the lesser omentum. You can see the section of portal vein and the bile duct and hepatic artery. And posterior to this opening, here lies the IVC and aorta. Okay, and this is vertebra, and this is greater omentum attached along the greater curvature of stomach, and here lies the lesser omentum attached along the lesser curvature of the stomach. Okay, understood? Now the blood supply we have discussed in the lecture, supplied by these arteries, all are branched from celiac trunk. Okay, artery of the foregut, left gastric artery, right gastric artery, short gastric, left gastroepiploic, right gastroepiploic. Left gastric arises from celiac trunk, supplies the lower third of the esophagus and the upper right part of the stomach. Right gastric artery arises from hepatic artery at the upper border of the pylorus, supplies the lower right part of the stomach. Short gastric arteries, they arise from the splenic artery and supply the fundus of the stomach. And left gastroepiploic artery arises from splenic artery, supply the greater curvature. And right gastroepiploic artery arises from the gastroduodenal branch of hepatic artery, supplies the stomach along the lower part of the greater curvature. So this is supply of these arteries. This diagram you practice. Okay, celiac trunk, left gastric, right gastric, gastroduodenal, from the gastroduodenal, right gastroepiploic, left gastroepiploic, and here is the splenic artery, and on this side these are short gastric artery. All these are supplying the stomach. Schematic diagram. You can see those arteries, left and right gastroepiploic, splenic, short gastric. Okay, and this is esophageal opening of the diaphragm. Celiac trunk, hepatic artery, gastroduodenal. Now the veins of the stomach, veins drain into the portal circulation. Here, this is the portal vein. Here is the splenic vein, inferior mesenteric vein, superior mesenteric vein, superior mesenteric vein and the splenic vein join to form the portal vein. Okay, right and left gastric veins, they drain directly into the portal vein. Short gastric veins and left gastroepiploic veins join the splenic vein. Okay, short gastric vein and left gastroepiploic vein join the splenic vein, and right gastroepiploic vein joins the superior mesenteric vein. Here you can see right gastroepiploic vein join the superior mesenteric vein. Now lymphatic drainage also have been discussed. Lymph vessels follow the arteries into the left and right gastric nodes, left and right gastroepiploic nodes, and the short gastric nodes. And all the lymph from the stomach eventually pass to the celiac node located around the root of the celiac artery on the posterior abdominal wall. This is the lymphatic drainage. See here, short gastric node, left and right gastroepiploic node, left and right gastric nodes. Here are the celiac nodes. All the lymphatics finally drain into this celiac nodes. Now the nerve supply of the stomach. Nerve supply includes sympathetic fibers derived from the celiac plexus and parasympathetic fibers from the right vagus. Right vagus is posterior vagal trunk and left vagus forms the anterior vagal trunk nerves. Sympathetic innervation of the stomach is inhibitory to the muscular wall of the stomach and carries a proportion of pain transmitting nerve fibers, whereas parasympathetic vagal fibers are secretomotor to the gastric glands. These functions are important. Sympathetic has which function, parasympathetic has which function, okay? And motor to the muscular wall of the stomach. Pyloric sphincter receives motor fibers from the sympathetic system and inhibitory fibers from the vagi. Inhibitory fibers means parasympathetic fiber. Vagi means parasympathetic fiber. Okay. So sympathetic system, it closes the sphincter. Parasympathetic fiber opens the sphincter. Okay, understood? See, the vagus nerve has been shown, anterior vagal trunk, and this is posterior vagal trunk. Okay. Here this posterior vagus is giving branch towards celiac plexus. Now these are some clinical aspects. Hypertrophic pyloric stenosis. Okay, it is a congenital. This comes as a short note. Hypertrophic pyloric stenosis. What is this? It is a congenital defect with a neuromuscular incoordination of the thickened pyloric sphincter. The infant suffers from progressive vomiting within 2 weeks to 2 months of postnatal life. And in such condition, surgical division of hypertrophied muscle may be necessary. Ramstead operation is done, okay, to treat this condition, hypertrophic pyloric stenosis. Now, section of the vagal trunk or vagotomy. When it is performed, this is also important question. Explain why. Comes in your explain why section or part of a long question, it can come. Vagotomy. It is sometimes performed to reduce production of hydrochloric acid from the parietal cells in patients with peptic ulcer. आगे पढ़लाम ना nerve supply. This parasympathetic supply is secretomotor. Parasympathetic means vagus, supply of vagus or secretomotor. That means it will help in secretion of HCl and different gastric juices. Okay, so you have to cut the vagus to prevent secretion of hydrochloric acid, which is increased during peptic ulcer. So it is performed to reduce production of hydrochloric acid from the parietal cells in patients with peptic ulcer in the stomach and duodenum. Peptic ulcer occurs in stomach and first part of duodenum mainly. Okay, and the vagotomy may be truncal vagotomy, selective vagotomy, and highly selective vagotomy. Different types are there. You have to learn these types during surgery. Okay. Next is peptic ulcer. Truncal means main vagal trunk is cut, anterior trunk cut or posterior trunk cut. Then from there some branches are there. Okay, branches of lateral jet they are called. They are cut. It is known as selective vagotomy. And highly selective, only the highly secretive area, the vagal branches supplying those areas are only cut. That is highly selective vagotomy. Okay. Now peptic ulcer, it results from the peptic digestion of the devitalized mucous membrane with the assistance of HCl. Okay. Ulcer affects the stomach, proximal part of the duodenum, that is more commonly involved in peptic ulcer, and terminal part of the esophagus. These are asked, all these, where peptic ulcer can occur. Okay, it does not occur only in stomach. Other areas can also be involved. Main involvement occurs in first part of the duodenum. Rest, this part can also be involved. If you cannot find the ulcer within the stomach, you have to find these areas. Okay. For ulcer, terminal part of esophagus, Meckel's diverticulum. This is remnant part of the vitalointestinal duct. Okay, Meckel's diverticulum. Sometimes the stroma of the jejunum after the gastrojejunostomy. Jejunum is not accustomed to the acidic environment, but if in due to some reason gastrojejunostomy is done, the acid will directly pass from stomach to jejunum and will produce that will produce ulcer in the jejunum. Okay, it is an interplay between the two factors. Ulcer formation, why the ulcer formation occurs? Aggressive agents of acid pepsin favoring the ulcer formation, and the mucosal defense mechanism which is preventing ulcer formation. If the balance is not maintained, there will be ulcer formation. Okay, and in case ulcer becomes aggravated, there may be rupture and bleeding. Okay, perforation in the stomach, then there will be leakage of food, peritonitis. Okay, you have to do laparotomy then. Okay, that's all. You know the presenting parts. You have to see two ends are the cardiac end, pyloric end. Okay, two curvature, lesser curvature, greater curvature, two surfaces, anterior superior, posterior inferior surface. Okay, and different parts of the stomach, four parts: fundus above the transverse line passing through the cardiac orifice, body from this transverse line up to the incisura angularis. Okay, from the incisura angularis up to the prepyloric vein of Mayo, that part will be the pyloric antrum. After that will be the pylorus. Pylorus consists of the pyloric canal and pyloric sphincter. Okay, so you have to see all these structure in the viscera.